the Andhra Pradesh Audiology and Speech Pathology Association. Andharakum Namaste and Namaskara. Thank you. Before we are going to the topic, we all may come across or may know maybe 50% of speech and language pathologists may know the role of occupational therapy. Basically, the people who are think the occupational therapists are doing the only the fine motor activities for the children, and few are thinking about they are doing for the independence or making the assistive devices for the people who are the dysfunctions, and few are thinking about they are working only for the academic activities for children. The occupational therapy only doing for the children development like that. But occupational therapy is not like that. Only specific things. It's the physically or mentally those who are have difficulty making independence in all the level is a assessment and a treatment and making independence in the all the aspect. This is occupational therapy. The occupational therapy not only working only children or adult, from the birth, from the NIC itself, they are working the starting. For example, the audiology people doing the hearing evaluation test for the newborn, for the identifying the early identifications. Same thing from the NICU, whenever the child is born in the world, the child may have the clear milestone, fine motor, gas motor, cognition, other milestone development will be checked by the occupational therapist. From the NICU, after that the child normal development, the neck control, the head control, and the crawling and the age appropriate milestone achieved or not, any reflexes are not integrated, the things and all assessed by the occupational therapist. Then the child going for the school, the child have the difficulty in the academic activities like communication, social interactions, and the academic activities, and the environment. The child may have the physically disability or any other visual and hearing impairment. The child have to assess the environment. The artificial barriers will be assessed by the occupational therapist. And if you're taking the adult, those who have the orthopedical, musculoskeletal, neurological, and mental health. In orthopedical, they have the any muscle injury, fractures, preventions, and rehabilitation. And for neurologically, those who have the stroke or neurological degenerative conditions, other things, they have to assess and they have to do the modification. Modification, not only the physical modification of the person, they have to modify the environmental. That is the real rehabilitation. If you're treating the children or adult in their condition, is not only independent. They have to interact with the community. They have to go for the school. They go for interact with the community people. They go for the temple. They do for the ritual work. They go for the recreational leisure activity. The people can go for the beach. They go for the mall. The accessibility is be assessed by the occupational therapist. The ramp. Nowadays, you can see the any government and private institution after the person with right for person with disability act 2016, all the institutions, all the government places and private places have the oxygen free, barrier free environment. The person, wheelchair person or any blind person or any other sensory person also, even nowadays in for autism, sensory processing deficit, all the airport, all the malls have the sensory room, because any individual, those who are a person with a disability, there's rights to assess the all the features, all the rights in the world. That is supported by the occupational therapist. So, and even in the mental health, psychiatry, we have the major role. Person with from like schizophrenia, mania, and other bipolar disorder, we have to rehabilitate till the vocational rehabilitation, family rehabilitation, in society rehabilitation. So these are the major areas of the occupational therapists are working in the things. And even you are sitting in the chairs, the many of the companies from India economical certificate by the occupational therapists. Our IOTA giving the economic inspection for the all the furnitures companies, those who are giving furnitures for the auditoriums, chairs, and schools and office and industry, all the chairs and how they can sit, how much the biomechanically they can sit, how much they can energy conservation and work simplification we can done. All things assessed by the occupational therapist. The profession otherwise called ergonomics, ergo medicine. It means even how to operate the laptop, how to work industrial work, all the things will be done by the occupational therapist. Is an emerging field in India, and it's very close and very helpful to enhancing the children with a problem in the disability, and they have the communication problem. The person will come for the speech therapy. If you child have maybe hyperactivity, the speech therapists have difficulty to handle the client. The child may have the physical disability like cerebral palsy or ataxia, like that means again they have the difficulty for the things. And even the neurological, even the psychotic people also, they have the difficulty to handle the speech language pathologist to enhancing the improving the communication. With the help of the occupational therapy, with the help of the techniques, the collaborative counseling approach definitely help the making the person with independent in the all the aspect. So the occupational therapist not only dealing with the person their problem, they're involving the environment and their occupation and the interaction of the both. So this is the main core of the occupational therapy interventions. Not only dealing with the correcting the only physical and mental disability of the individual person, it involving the society, the person should be interact, and barrier-free environmental will be created by the occupational therapist. So coming in the pediatric occupational therapy is a major role occupational therapy playing, because the occupational therapy working in all the field, pediatric, ortho, neuro, psychiatry, other things. But coming in the pediatric, it's a challenging and also very interesting, and along with the other team, medical team, pediatricians and psychologists, speech language pathologist and physiotherapist and pediatric special educators. So they working along with the team and making the independent and making the improvement in the child communications and the overall performance. So we are focusing on the major areas, mainly fine motors. Fine motors is very, very important for children daily activities. The child want to brush, child want to buttoning, child want to eat, they need the fine motor activity. And they want to write and they want to communicate, they need the fine thing, motor things. And the same crash motor, that is the running, jumping, all the things. And we are working on the cognition aspect. Mainly they need attention, concentration, the problem solving skills, these areas, and the most properly sensory integration. We all know we have the five senses and we have the very important for the things. Apart from the proprioception, the vestibular, clearly have the vestibular integration, vestibular rehabilitation is very, very important for the communications. So we are working on the vestibular and proprioception thing is very, very important to enhancing the child communication thing. And as well as the visual perception and motor planning, because the child need the executing the motor planning, whatever thing. Normally, if you are walking or we are speaking means we need the motor planning, the executing the praxis. The areas will be most concentrating by the occupational therapist. Then only the child can dress well, the child can speak, the child can communicate other things, and mainly the daily of activity, the activity of daily living. Major of the student children's special needs parents have the burden, mainly the indicating and independent doing the daily activities. You may come across many children from autism and sensory processing. They have the problem in the indicating the toilet need, and they doing the independent in the dressing, and even the eating also is a very difficulty. So these areas will be addressed and rectified by the support with other team members by the occupational therapist. And oral motor areas and play. Play is a major role, major important component for the children to be interactive with the society. So through play activities, we are doing the interventions, and the child can get the proper input, and the child may use the input and they can enhance the academic and social communication emotional skills. So now I'm telling the important part of the how the sensory integration, sensory processing very important for the child communication. So initially it's called the sensory processing, and now it's the sensory processing dysfunctions. Uh, Actually, I just outlining the main thing only. No need to overlap other all the things. The main thing, see, you can see when the child is become a normal citizen means the child can academically do good work and the doing independently age appropriate aerial skills like dressing or eating other things and behavior. It should be proper manner means we can observe, okay, the little chom doing good work is doing well communicated, is speaking, he is going to school, is a pre-kg, he interacting with the people, he participates in competition, he is doing good dressing, other things and all. But for achieving these things, we need the behind there are auditory, visual, and the attention, eye and coordination. These things will be developed properly. Then only the child can be achieved the major uh, activities. For this eye and coordination and the motor and oral spatial control, that is called praxis, and that is auditory processing and the vestibular input. Before that, that developed because of the basic sense, that is proprioceptive things. Once if your child have it will be affected this coordination work, and it will affect the child, the outcome of the child are very poor in the communication, social interactions, academic and ADL, other behavior things. So we can observe the child lot of difficulties because of the problem in the sensory processing. So, for example, visual. If you're taking visual, normally in a sensory processing, maybe the child have hypersensitivity, that is increasing the level of normal sensation, or hyposensitivity, it will be low level under response from the normal things. If a child have equal manner, normal manner, then only the child can understand receiving the sensory input from the outside. The sensory processing like that, the child have to receive from all the through senses, they receive from the information from the environment, processing the environment in the sensory integration, and output should be go for the successful manner. If the process will be happen, the child can do normal things. The child born and the child develop physically, mentally, and the child educated and child do all the life scenario. But if a child have any difficulty to receiving the sensory process, or any problem in the processing, that's a comprehension, any processing means they have difficulty to interact, the daily activity affected, plays affected, and academics will be affected. For example, in a visual, if a child have hypersensitivity, the normal visual things, for example, the lighting, the projector is normal for us. But children who have hypersensitivity, it's very, very painful. It's very big distraction. So child can't sit or viewing the normal thing, physical things. And if your child have the under response, the child easily distracted. They are easily, we can see the child very distracted, the child not maintain eye contact, other things and all will come the under response because it's not developed properly. If a child, some children have the seeking, they seeking the once the movement object, like you can see the autistic children, they're seeing the fan movement and they're achieving the wheel movement, and what are the moving object they are seeking, because the processing is not happening properly. So the occupational therapy intervene and making whether hypersensitivity we normalized, hypo we have to make the normalized things, and if we're seeking we make it a normal thing with the proper sensory integrations. Same thing. Mostly the speech and language pathologists can see the symptoms like this. Even if parents coming to your clinic, they are telling child have 2 years or 3 years. Whenever we are calling, the child not at all listen for the things, our name calling or whatever things. Then they go for the auditory testing. You do the what is the BERA, even you are doing the audiometry impedance or BERA, whatever may be, you can't find out any difficulties. The all the things are normal, but why the child not listening now, or why not child not respond for the name calling means the processing is the difficulties. It is called maybe the child may have the under response. Some children have hypersensitivity. The normal name call may be very sensitive for the child. For example, the normal sound, mic sound, normal mixy sound, normal fan sound is a normal thing. Is already normally integrated. But children who have the difficulty, even the normal TV sound or mixy sound is very difficult. Though child can't stay in the places. For example, child have the hypersensitivity in the going for the toilet, the flushes sound it may be horrible for the child. One person is a name called is Narayanan. He is autistic person. Now he's maybe 50 years and above. He wrote the book is the wasted talent. In the book, he written clearly the senses from the outside. It may be we are perceived means the lion. One lion is scraping the with the nails, that much of pain we have whenever the sensory touch will be happen, whenever the auditory will be happen, we have the feel like that. Or two rocks will be crossing each other, they have the pain, that pain we are feeling, that much of pain the child will feeling. You can see the champ, the little champ have cried, they are very much discomfort. Normal sound, normal classroom atmosphere, normal home atmosphere, normal social atmosphere, the child can't listen for a movie, the child can't go for the park, the child can't go for the normal what all the child want to learn, the child have difficulty because of the sensory issues. So first we have normalize the process, then only child can listen. Child can listen your speech intervention. Child can listen your auditory processing issues. Child can listen for your communication. Then only child can speak. Same the accessory oral. The child, some children have very eager to the eat some particular food. Some children avoiding the food. Normally the child not at all take the food properly. Maybe hypersensitivity, maybe hypersensitivity. Some children particularly non-eatable things. They will eat the non-eatable things, pepper, mud. They are eating like this because of the sensory processing difficulty, olfactory. So these things very important because olfactory, if a child doesn't know the senses properly, is maybe abused. Maybe we in early childhood also we are very fond to the normal petrol smell. Normal we call the kerosene. Kerosene smell and all we are like, but if you inhale more, it will affecting the our cognition and central nervous system. It will be harmful to the child. So if a child doesn't understand or overwhelming for the abnormal smell means it will be affect the child's central nervous system. Likewise, child may get abused. So it is a very, very crucial part to identify the child, whether it is hypo or hypersensitivity. Even child have the very sensitive for normal smell. You can think about normal sambar smell, normal masala smell is will be affected means the child can't eat the food. Normal perfume smell is affected means the child can't enter in the bathroom. If a normal perfume or normal room perfume is affected means the child can't enter the classroom. The child can't continue their work. Even you can see the play toys and all. The play toys or crayons also have some smell. It's like even if you have taking the new textbook, you, ever you have smell the new textbook? If you take the new textbook, they have the some kind of smell. It's a nice smell only, but that smell also not at all tolerant by the children who are sensory processing problem. Now think about the child can't play, the child can't read, the child can't do the crayons work, the child can't do play activity, child can't go toilet room, child can't go to bedroom, a child can't go to kitchen. Then what the child can do? He very cry and a very uncomfortable situation. We have to make the sensory adjustment areas. So this is a huge issue, sir. This is very you can commonly see in children who can't do the hair cutting, not wearing the good dress. Some children very hypersensitive for the normal dress. They are toe walk. They are not touching even. If you're taking food, they are just sweep the food things, and they, if you are someone touch, they would not allow the touch. The child not interact with the group. If you have hypersensitivity, if a child have hyposensitivity or eagering seeking means they keep on pinching or they keep on touching the people and they are chewing the not needable things. So like hypo, hypersensitivity and the seeking will be happen in the touch. This is a very important proprioception. Proprioception is a sense will giving the how our joint is positioned. For example, you are sitting. Now you can realize your knee is bending and your hand is bending. The sensation from the joint. There in our body, joint will be there. In between joint, we have the called synovial fluid. If you the synovial fluid will be very dry, means then only we can have the or erosion, we can have the rheumatoid arthritis, the all orthopedic difficulty. So the sensation will be go for the brain, telling that your movement.
Very first talk of the APASLPA Conference 2025 with such insight and thoughtfulness. You have given us a deeper understanding of how sensory integration directly impacts communication development and, more importantly, practical approaches we can take to support children in more holistic and meaningful ways. We truly appreciate the clarity, compassion, and depth of knowledge you share. I'm sure many of us are leaving it inspired with new ideas and a renewed sense of purpose. Thank you once again for your valuable contribution to kicking off today's conference. Now, before we move on,
Yeah. Rashika sir wants to add some comments.
Not questions. I think questions should be asked by the younger generation. Okay, just want to offer comments. I just wanted to congratulate Dr. Arun for an excellent insight into what occupational therapy can do. How relevant is the sensory integration, especially communications. I'm saying this because I, being an SLP and audiologist, I knew nothing about occupational therapy till I took over as the founding dean at the Manipal College of Health Professions, where PT, OT, our audiology and speech and all were part of the same college, right? I'm talking about 1999, about say 25 years back, where everybody was clamoring to get admitted into PT. Anybody ask, what course you want? Physiotherapy. physiotherapy. As a dean, they'll come and ask me, sir, which course is the best course? I'll say all the courses are equal. You ask a father, who is your best son, best child? Every very affectionate to you, Preeti Unaru. You always say that everybody. So I say, as a dean, for me, all the courses are equal. Somebody comes and tells me, we have taken occupational therapy. What do you feel about it? I said, excellent. You've done a wonderful job. Because I've seen them, I've seen them work. They are actually the silent heroes, unsung heroes. Okay. Whereas if you look at the physios, I have nothing against physios. I got good friends in physios also, but they're very dominant because of the number. Okay, so the lack of awareness was there. So we had very few admissions in the OT program. It was single digits, and every time I go to my chancellor, he'll ask, when will you double it? Okay, but awareness came and people saw them working, right? And it's always, you have to do it, right? So they say, the taste of your pudding is in, the testimony is in tasting it. So once people are aware, they have seen how these people work, the numbers started increasing, right? And now occupational therapy is one of the most sought after professions in our college in Manipal. People come with 90% and above and ask for this. They're not getting the seats. And we got excellent, the alumni have all gone overseas. And the collaboration between the SLPs and the OT is something which, we have to foster it. Because we have to work together as a multidisciplinary, be it dysphagia, be it swallowing, or be it, in the sensory integration, all this, their contribution is really ideal. Okay. So in that context, now I would really congratulate the organizers for inviting him for this talk. Because, we as SLP should be aware of, see, it's not that, we alone can do it. The stakeholders in anybody with a communication disorder is multidisciplinary. Nobody can take the credit that, I have done it. We have done it. So OT forms one of the very important, especially in ASDs, autism spectrum disorders and all that. So you people will have to coordinate, collaborate with the OTs, right? Take them on your WhatsApp group, right, or a Facebook group, and see what they're doing. Because if you collaborate with them, you're ultimately giving the benefit to your client. And ultimately, what is our goal? We want to give the best to our clients. Correct? So that's what is the most important. So I really congratulate the organizers for, opening the session with the relevance of occupational therapy and sensory integration. I'm sure all of you will take this lead and then, get more interested in what the OTs do and collaborate with them. Okay. Thank you for an excellent talk. I really loved it.
Thank you very much, sir. We would like to take few questions from the participants. Before that, I would like to request chairpersons to share your thoughts.
It was an exemplary presentation, sir. So far, wherever we are attending this conference, we used to talk about lot speech language pathology, what we are doing it. When you club this OT, it has become a very we are getting that tremendous changes in the people with all the disability people, where especially with these children's, where they are lacking in these professionals in the speech language pathologist, where the people are giving the therapy sessions in our institutions. There is to be a lot of improvements can be done so that a child can lead a better life like normal. As you mentioned that RPW Act 2016, definitely we are implementing that one, then it will become a tremendous change. We are getting the speech and hearing field, and the child become a normal, they can go for the mainstream. Thank you, sir. Thank you so much for your wonderful presentation.
Thank you very much, sir. Are there any questions from the participants?
Yeah, Dr. Arun would be available, so you can ask questions during lunch also. We are running short of time, so we'll go ahead.
Yes. Thank you. So as a token of appreciation, I now invite Dr. Rajshekhar to kindly come forward and present a memento. Thank you all for your valuable contribution. Now we'll move forward to introduce. Now it's my pleasure to introduce our next speaker, Dr. Srividya, who will be presenting on a topic that beautifully bridges neuroscience and clinical application, application of cognitive evoked potentials. We are honored to Dr. A. Srividya, a distinguished professional in the field of audiology and speech language pathology.
Okay, 1 second. Without mic, all of us can hear you. Then, no? Can anyone hear me? Everyone can hear, no? I will not use a mic. That's why I'm asking.
But mic will augment your.
Okay, sir. Okay, so this is going to be a little technical presentation about auditory evoked potentials, and we are going above and beyond ABR. ABR is something which all the students know, everybody knows. We are doing it in and day out. But now we have to think little ahead, and we have to see how we can do higher potentials and which cases we can do these potentials. The idea is to introduce these potentials for especially for students upcoming. As decades back, 30 years back, we used to do pure audiometry. Later, we started doing ABR as a regular routine evaluations in audiologists clinics. Now there'll be time another 5-6 years later, 10 years later, next decade, there'll be cognitive evoked potentials, which will become a regular routine test battery approach. So it's better we know a little about it and why we are doing it, who are the right candidates whom we have to administer this test. The idea is that to introduce this concept and this practicality to the students. Is that okay? Yeah? Louder. She told me I'm teacher, so I have to show myself. Okay, so we are doing applications of auditory evoked potentials. We will. Okay, we will see what are evoked potentials, how is it different from a regular ABR which we do, and which cases we can do the cognitive evoked potentials. Now what, as a definition, we all know evoked potentials are nothing but the brain stimulations, electrical pulses which are generated at neuron levels, which are picked up by the electrodes which we place at different positions of your head. If you all, I mean most of you know about ABR, you place the electrodes, you pick up the signals which are coming out of the scalp, correct? So we are basically detecting the electrical potentials which are coming out of your brain. But this is done using EEG also. How are we doing it differently? We are giving a stimulus and we are seeing how the potentials change as the stimulus is generated. If the stimulus, you're giving a particular click or a tone burst or a speech stimuli, how is the brain reacting to those stimuli is what we are recording using our ABR or any auditory evoked potentials, right? So when we do cognitive potentials, we usually do it in cases where we have to see above the threshold estimation. What we do usually doing ABR is threshold estimation or trying to see if it is a cochlear pathology or a retrocochlear pathology. Yes, agree? But when we are doing cognitive evoked potentials, we are trying to see above the sensory part, you are looking at the processing part. how the brain is processing your stimuli. Either it is a non-speech stimuli or a speech stimuli. How is the brain processing it? Is he able to understand the speech stimuli? Is he able to differentiate between the phonetic sounds like ta and da? Is he able to differentiate? Is he able to differentiate between a short vowel and a long vowel? These smaller aspects also can be detected using evoked potential. Why we should do that? Because in cases where infants are there, where we cannot do that in an object, in a subjective test, in a test, behavioral test, or we can do it in cases where we have to see a difference in putting a hearing aid. Is there a difference in the child's perception? In those cases, we do evoke potentials. So these cognitive evoked potentials are done where we cannot subjectively assess if the person has a processing difficulty or not. Right? Usually processing difficulties are assessed using a behavioral test. Like you have your CAPD test. Yes, you have your scan test, or you have your speech perception in noise test. You have your digit count test. These are done in to assess if the child is able to understand the particular sound, particular stimuli when we are talking to them conversationally. But these responses cannot be obtained in infants, or it cannot be seen in terms of how the amplification is helping in understanding, processing it. So that is where your cognitive evoked potentials come into picture. Now this is usually what we do. Yes, I don't know. Okay, this is what we usually do in our ABR. First to fifth peak. Yes, agree? So we are seeing something above this. That is, when we are seeing the fifth peak or ABR peaks, we are seeing within your 10 milliseconds, 15 milliseconds. But above this 50 milliseconds, what we are seeing is your evoked potentials. Why which is important for us? Because your speech stimuli is a longer stimulus. When you are giving a click or a tone burst, it's a very short stimulus. So your response will also be early. But when you're giving a longer stimulus, a speech stimulus, the stimulus is longer. So it will take time to come back. Your response to elicit your response also will be longer. So you record it after 50 milliseconds. So what we are recording is after 50 milliseconds. And if you see, when you're doing an ABR, we are only seeing till your inferior colliculus. Yes, your seventh peak. Yes, agree. Okay. So if we are seeing the seventh peak, but when we are doing cognitive evoked potentials, we are actually seeing above the inferior colliculus in the cortical areas. We are trying to see if the child is able to understand the stimulus, not just hear it, not just listen to it, but is the child able to differentiate between the phonetic sounds, between the speech stimuli. The child is able to understand in the presence of background noise. This can be detected using your cognitive evoked potentials. Now, what is the basic difference? I hope all of us know. When we are doing ABR, we are doing within a short stimuli, within 10 milliseconds. We are giving clicks and tone bursts and we are trying to get the response. But when you are doing cognitive evoked potentials, we are usually giving complex stimuli. We are either giving recorded CV sounds, consonant vowel sounds, or vowel sounds with prolongation, or we are giving words, or we are giving sentences also sometimes. So the stimuli is become more complex when we are doing your evoked potential, cognitive evoked potentials. And also, when we are doing cognitive evoktions, we are not just checking their hearing. We are checking their attention, their memory, the decision-making process. Are they able to decide if the sound is different from the other? Are they able to understand in the presence of noise? Are they able to comprehend a male versus a female noise? I mean, as Arun sir said, sensory is not just enough. If you are hearing a sound is just not enough. You have to process the sound for you to able to express it better. If somebody is talking to you, if a male person is talking to you and you don't realize who is talking, then you cannot respond. So unless it is just hearing, it is one level above your hearing, above your sensory level. Now we also call them as endogenous. Cognitive evoked potentials are also called endogenous potentials. Why? Anybody? What is the difference between exogenous and endogenous potentials? Sorry? Yes, exogenous potentials, I don't ping, he don't have to cooperate with me. You can give him a sedation, make him sleep and do that. But endogenous potential, I need patient's attention for the stimuli. He has to listen to the stimuli, he has to be awake, he has to take a decision. Right? Battery is running low. So we will be covering 4 kind of potentials here. We have LLR, we have P300, we have MNN, and we have N400. These are the complex 4 cognitive work potentials which we analyze. We use this using all the stimuli, all the potentials are usually done using speech stimuli. It can be a single phoneme, or it can be a CV combination, or it can be a word, it can be sentence also. So what we usually doing, your LLR is your P1, N1, P2 potential. That is one level above your ABR potential. Now this is usually done using your phoneme, or you are using your difference between 2 phonemes, P and B, or A and A. So this kind of 2 small stimuli we give, and we'll see the P1, N1, P2. When it comes to P300, you can even use words. You can give two different words and see if there is a potential difference between the response elicited for one word versus the other word. We usually give an oddball paradigm where we give a series of same word. In between, we introduce a new word. So is there a difference in the potential elicited by the brain when we give a new word? The novel word, does it generate any response? So that is what we are seeing in P300. And how much is the difference for the new novel stimulus is what we analyze using your mismatch negativity, or the MNN, right? And we have something called N400. N400 is again a very high complex stimuli. We are trying to see if the patient is able to understand the difference between these stimuli. For example, usually N400 is done with a small phrase or a sentence where there's only one word difference or one sound difference, but the whole sentence, the meaning of the sentence changes because of that phoneme or the word. So we are trying to see if the patient is able to understand the meaning of the sentence based on N400 potential. Now what we do in L1P2, I hope all of us know this electrode placement is quite different from your ABR. ABR we usually do 3 electrode or maximum 4 electrode placement. When it comes to higher potentials, electrode placements is more. Why? Any idea why? Why we should have more electrodes, or why we should have the placements different? Because the site of generation is different. We are looking at more proximal places to the brain, not to the ear. We are going more deeper. So the placement of the electrodes is more where these potentials are generated. So these electrode sites, electrode location or electrode placement is varying based on the location where you want the potential to be recorded. So this is usually the P1 N1 LLR potential, cognitive work potential, and this is the negative peak, this is the positive peak. We see the difference between the 2 peaks. We usually give without, P1 N1 P2 is usually done in aided cortical potentials, where we see with the hearing aid or with the cochlear implant, is there a difference in the potential, difference in the person's speech perception ability. So we see a difference in P1 or P2 values, latency and amplitude values with and without the hearing aid. So that is usually the application of P1 N1 P2. We will see in few cases how it is. And this is P300. This is the electrode placement. The electrode placement is much more closer to the brain. We have CZ, FZ, PZ. CZ is your midline placement, central head. Midline placement is a 1020 electrode system classification. We have the FZ placement, which is more frontal area. PZ placement, more the parietal area. So we are trying to see if the frontal parietal areas are generating the potential for your speech stimuli, because our speech stimuli is more frontal areas. Yes, your comprehension more is the frontal area. So here also we get a P300 response, which is usually seen at 300 milliseconds. So that is the reason it's called P300, positive evoked potential. We have the N400. N400 usually is done with an electrode cap. Your 4 electrodes or 5 electrodes is not enough to record an N400, because the stimuli itself is complex and there are a lot of electrode locations where the potential is generated. So we usually have multi-electrode placement. So we usually use an electrode cap to place the electrodes, and we see what is the difference in the N400 effect. We see N400 effect. What is this? I said N400 is to understand if the person is able to understand the meaning of the word. So if I can give 2 words, like a minimal pair, I can give a 2 words, which because of one sound or one longer vowel or a different vowel, the meaning changes. That way, I will give one stimuli, I will give second stimuli. I will see how much is the difference. If the difference is more or less, that depends on your ability to perceive the difference in the meaning of the word. So N400 is usually done at a very higher level in terms of understanding capability. Why we should do all this? We can as well ask the patient, is he able to differentiate? Why do we have to do a potential? One, it is objective. It's an objective assessment of the person's perception ability. Two, this can be done in patients like autism, patients like infants where you cannot ask the patient. We can do it in patients who have cognitive ability decline like dementia patients, people who have difficulty in expression but they understand better. We should know what all sounds they are able to understand, how much is the perception ability, though they are not able to produce the sound, are they able to perceive it properly or not? So in these patients, we have to do the objective assessment and electrode potential. So it is important that audiologists understand that we have a role in these areas. It is not just threshold estimation using ABR, or it is not just trying to understand if the patient is able to hear or not. Patient is able to understand or not is also our headache. When you put a hearing aid, okay, he has a 60 dB loss, you put a hearing aid and send him, he comes back 100 times saying, I am not able to understand. It is loud, but I am not able to understand what is happening. Why? Because his perception ability is improved or is worsened. With the hearing aid also, the hearing aid is making it louder, it is amplifying, but it's not helping in his perception. Which we can analyze, we can realize why his perception ability is affected, which area is affected, is in the cortical areas, which area is affected using your cognitive work potentials. And this cognitive work potentials can be used to see how much is the effect of the aid. You are giving a hearing aid, you are giving a different types of hearing aid, you are giving a cochlear implant, you are mapping the cochlear implant. In cochlear implant also you have channels, you have number of electrodes. The electrodes mapping can be varied based on these potential results. We can say using these two minimal pairs, for example, for per and bur, he could differentiate, but for sir and sure, he could not differentiate. Especially in infants, you cannot ask them, are you able to differentiate sir and sure? But when these potentials are recorded, you know that his high frequencies are affected. I can make a difference in their mapping, in their programming of the hearing aid. So we do have a role in your cognitive work potentials which help us in management of the patient. So we will see what are the applications. In CAPD, especially in central auditory processing disorders, most of our CAPD tests can be done above 6 years of the age of the child or 7 years of the age of the child. Especially when they are just entering school, most of our test material we cannot do it, behavioral tests cannot be done. But evoke potentials can be done at any age. We can detect if the child has a processing ability or sensory ability, sensory processing difficulty or a sensory difficulty. So we usually see in CAPD that the mismatch negativity or the MMN, the amplitude and the latency values changes. We see that there are delayed MMN latency, and which tells us that they have a processing difficulty. It takes a longer time for them to listen to the sound and understand the sound. Right? MMN usually tells us if the latency is improved, what does that mean? It is taking a longer time. The time in what? Information processing. I tell him it takes a longer time for him to process and then respond. We keep on giving input, he will not respond because he's not able to process it. So this will help us understand the patient properly instead of shouting at him, telling him 100 times, putting him on revision. You know the patient has a processing difficulty. So the approach you do during your management changes based on your results. So we also see P300 is absent in cases of CAPD. They are not able to detect the smaller changes in phoneme or word, especially for speech stimuli. There are P300 which are recorded for small clicks also, small tones also, like we give 1 kilohertz continuous tone and 1.5 kilohertz. So they are not able to differentiate the difference between the frequencies. P300 is absent means what? They are not able to differentiate. This you cannot do using your pure tone audiometry or an ABR. Correct? Will you be able to assess the patient's frequency differentiation ability or an intensity differentiation ability or a sound differentiation ability? You cannot. Especially when the child is in school going child or less than a preschool child. This evoke potentials help us there. Now there are a lot of studies done in CAPD in cognitive evoke potentials. They all say that before your behavioral test tell you any information, evoke potentials can be a biomarker. That is, it can tell you much earlier that the child may have processing issues, the child may have learning disability, the child may have autism, the child may have issues in terms of sound tolerance. All this can be assessed using your evoked potentials, cognitive evoked potentials. Now we also, as I said, we do aided CAPs, that is your P1, N1, P2 are these the potential which we usually do using your aided, using your hearing aid and your cochlear implant. So what we do, this is usually the setup. We give the hearing, we put the cochlear implant or the hearing aid. We also do the electrode placement. We give the stimulus. We also see the P300 or the MNN recording to see if the frequency changes are being heard by the child. If the child intensity changes, 20 dB sound, 30 dB sound, that can also be done. You can change the intensity, 20 dB 10 stimulus, 30 dB 1 stimulus. Is the child able to differentiate? The child will not be able to do that during a behavioral test, but auditory evoked potentials can help us detect smaller differences in the processing of the child, right? So usually when we do auditory evoked potentials in cochlear implant, we see that the P1 latency is significantly delayed. What does that mean? When it is delayed, the child has information processing disability. That is, the child is not able to process the information like a normal typical child. It takes a longer time for the child to understand the word or the sound or the meaning, right? So they also see that N1 component is weak and poor P300 responses. They have done this aided cortical responses, unaided and aided. There are studies which have been done as a progression. See, for example, this one, before the activation of the cochlear implant, at different months duration of the cochlear implant usage, how did the P1 vary? You can see there's no P1 response increasing as the implant usage increased. So this you can do it in infants. When we usually advise the 6 months, 8 months cochlear implant. How do we test if the cochlear implant is actually useful for the child? This is an evidence-based practice. It can tell us that the cochlear implant is useful for the child and it will help in speech production. There are cases, even with a cochlear implant, the speech language, there's no much development or there's no improvement in their speech language. When you do your Reeds test or CCS, we don't see much difference. Why? When we do this, we will know the child is hearing, but he is not processing. So the management during your AVT will change. Management during AVT will not just to enable awareness identification difficulties. It is also about the processing difficulties. So how you give stimulus to the management, training the child during an auditory training will vary based on your responses obtained in the evoked potentials. Now again in dementia patients, it is highly useful. Why? Dementia are older adults. They can tell if they have difficulty in discrimination of sounds, or if they are not able to differentiate between two words, they can tell. Why we should do evoked potentials? Any idea? Dementia is usually seen in older adults. They can tell us during the behavioral tests. Why should we do a evoked potential? Any idea? Sorry? Small responses, small differences, fine differences in discrimination, differences in processing latency. Usually when you see older adults, you'll have to tell them 100 times before they respond. Why? Not because it's always sensory, not because they cannot hear. They take time in understanding. They have lived their life. They know what is dinner, what is particular vegetable, but they take time to understand it. Why? Because they have difficulty in the cortical areas. There's a cortical atrophy or cerebral atrophy. There's a decay in those areas. The processing is later. Latency is increased. So what will happen? Why we should do that? Okay, latency is increased. Now why? How is it going to help us as an audiologist or as an SLP? How is it going to help us? Okay, I found out that that fellow has information processing difficulty. Now what? Yes, especially during therapy. Your cognitive behavioral therapy introduction helps. It is not just sound-based therapy. It is more cognition-attached behavioral therapy which will change. So your approach during a management changes. Now, P300, usually we see that there's a latency increase and amplitude reduce, but there are patients, I was just discussing with some of my colleagues, here we had done TDCS in dementia. TDCS it's a management strategy where we try to give, we activate the neurons using your electrical current. It's like what you do during your seizures. There are patients who have seizures, who have high potentials which are generated in your brain. That's when he has the tremors, correct? Now this can be reduced using your treatment strategy. In TDCS, what happens is all your electrical potentials or your brain neurons are deactivated. There's a less generation of the potentials. Now how can this be increased? There are strategies. We call direct current stimulation. We give the current during the using the electrodes, we give current. When you're doing ABR and EAPs, we take out the current, we pick up the potentials generated by the brain. But when we do TDCS or TMS, there are different approaches where we give current to activate your brain nerves. It's like your pacemaker. When you use for your heart is pumping slow or it is not generating the electrical pulse, then you give a pacemaker so that the electrical pulse starts and the heart starts beating again. Similarly, we have a TDCS or TMS facility. That TDCS is transcranial direct stimulation. We place 2 electrodes and we try to see, we activate those areas where the electrical potentials are less. So that's a big application in case of dementia, schizophrenia and all these patients. Why? Because when we see the evoked potentials are delayed, amplitude is less and the evoked potentials are absent, it is getting worsened by time. These management strategies can be applied to activate the brain neurons. Okay, so we have application in Parkinson's disease. Similarly, we see the MMN being reduced in amplitude. We also, this is a big application again in coma patients. We are usually called to see MMN. In coma patients, there is no responses, no reflexes. The doctors are not able to take a decision if the ventilator has to be removed, if the patient has to be let go. In those cases, usually MMN, if done and there's a potential, we see that there's some neural response or a sensory response for different kind of stimuli. So this MMN gets applied there also. There are studies done in schizophrenia, there are studies done in multiple sclerosis and amyotrophic lateral sclerosis. These are neurological conditions where the patient cannot tell you that he is not able to perceive or is not able to differentiate. We can do it using your cognitive work potentials. So the basic idea why we are talking about cognitive work potentials today, because we have to think beyond ABR. It is not just threshold estimation. It is not just trying to see if put the hearing aid or not, or put the cochlear implant or not. How to map the cochlear implant, how to map the hearing aid, how to help him in delayed processing, how to change your management strategies. This is something audiologists should know. So cognitive work potentials are coming into picture. We will be, in fact, forced to do cognitive work potentials above your ABR. So it's better we learn about it. We know what kind of a stimuli has to be used, where the electrodes has to be placed. What does it mean when I say P300 is absent, when MMN is absent, what does it mean? How to help that in your management strategies. So we better know about it. So the idea is, especially students, think beyond ABR. Don't get stuck with ABR. Think beyond ABR, because ABR is useful only for congenital deaf, to do threshold estimation, to do CP, RCP. But above RCP, what is what cognitive work potentials tell us, right? Done? Thank you. She doesn't need a mic.
I don't need mic.
You need a mic to answer.
Very quickly, thank you, ma'am, for your excellent presentation. I just wanted to know very quickly about the stroke patients. Once they have Wernicke's aphasia, they'll not be able to tell the right answer. So Parkinson's, Alzheimer's, I can understand. And if at all we provoke a little more, they are able to answer it. But stroke patients, to convince the attenders, that, he might not be listening also. That's why he is not responding to the therapy. That's where we are confused. Can this help us?
During your aphasic stroke patients, because N400 is word level. It's a semantic word level. What usually Wernicke's or Broca's have is not just sound level, sensory level. It is more processing level. And we are worried about their understanding, their comprehension and expression part of it. We know, all of us know that Broca's aphasia, Wernicke's aphasia, not everybody has hearing loss. They don't have hearing impairment per se, but they are having hearing processing difficulties. So when we use potentials, we can detect. In fact, N400, yes, but N400 can be done in spite of the hearing loss. You can increase the threshold level and give the stimulus. Yes. Yes. So that is where your electrode placement helps. You can place the electrodes in the opposite side of the, yes, opposite cerebral hemisphere.
Do we have any studies of N400 with the ANSD cases?
ANSD cases,
ANSD
I don't
cases.
have any studies. I have not read anything,
So
but yes,
what could be
there
the-
should be application for that. Yes. The problem with doing these potentials and why not so many studies is because the potential is somewhere deep inside. So your EEG is much higher and these potentials has to be detected. So the instrument should be so accurate that it, in spite of the continuous EEG and the auditory stimulus responses, you are able to detect these potentials. But there is one study which is done in US where they have seen ANSD, CI and NSD. They have to try to see if the CI is helping the NSD patient. So, but they have not done N400. They have done other potentials. So I don't have much idea how they did it. But there are studies in NSD.
Okay, this is just a comment on this. Excellent presentation. Okay, and you should be very proud because she is from undivided Andhra Pradesh. She is a Manavadu, right? Though she has settled down in Bangalore, but she has her roots in Andhra Pradesh. And I have very fortunate to have known Srividya from the time of Dr. S.R. Chandrasekhar. I was in a doctoral advisory committee also. Zeal for learning, and in fact, this topic is of great relevance, as she rightly said, going beyond. All of us talk only ABR, bus, but we have to go beyond that. That's what is called evolution. That's what is called, that you are going one step ahead now. I should very clearly told you about applications where we can, the audiologists, we have a role to play even in these cognitive potentials. So I think, I must really appreciate, and the way that she told the real teacher, the way you asked, understood, perception, that, I'll tell you, Srividya is a blend of teacher and researcher. The name Srividya, is Saraswati, endowed. No, see, I am very liberal in appreciation. But, okay, but I'm very restricted in criticism. Okay, I'm not appreciating, I'm telling you. So, researcher, fantastic. And in fact, the way she said about this could be a biomarker for early detection is very important. CAPD and its application, right? So, in cochlear implant, the AVT again, why there is no improvement? Well, if you do this, you'll understand what's the reason for it. So, its application in dementia cases, CBT, then when you apply the transmagnetical also, all these are kind of it will audiologists, in the rehabilitation. Just not you just test. And rightly said, you give a hearing aid, the best hearing aid in the world. The patient says, I can hear, but I can't understand. So what's happening at the higher level? So she took us beyond the cortex level. This is like, this topic is of great relevance because a lot of articles are coming up, a lot of research is being done. This is for audiologists a revolution, like how Gabriel revealed the concept. Praise be upon him. Similarly, this is also a concept with audiologists. We have to take very seriously, and there are a lot of research going on. As rightly put forth by Srividya, I'm sure that this is going to be a part of your routine testing. You will go beyond the ABR. Okay, so I think you really very clearly, you had brought up the role of cortex and how these are going to be the future. So thank you so much. Really enjoyed your talk. Okay, give it a big round of applause.
Thank you very much, sir.
Special round of applause for Manamadu. Sorry, Manamai Chesaru. Sorry, he's correcting me. So loss of Bangalore is a gain of Bagalkotu. So now the Guntur and Vinjanampadu.
Thank you very much, sir. I would like to request shades to shed the light on the topic.
Yeah. Thank you so much, Srividya, for such an enlightening talk. You made processing the cortical processes more simple, more easy for the students to understand and give them another route where they can think of doing what is beyond what they're working. So you're not just testing or diagnosing, but your role is increasing. You can play a very big role in also understanding the outcomes of various tests, understanding the outcomes of what all devices that you are giving to the individuals. So keep your minds open, start learning new things, expand your horizon. You can do a lot. So you're not just doing tests, but going
Actually, we are
beyond.
all fighting to be one of the health professions. We have to work in a hospital setup with a team. As sir said, we cannot stand alone and do some rehabilitation. We have to work as a team. We have to work with ENTs, neurologists. We have to work with speech pathologists. We have to work with OTs. Unless you upgrade your knowledge, you will not be able to work as a team member. If you're still sitting with pure audiometry and ABR, they will not value us anymore. We have to show them that we can go behind cortex
Yes.
level.
We have to show ourselves what we know. Right. Thank you so much.
Thank you so much, ma'am. Thank you so much, Dr. Srividya, for that highly informative and thought-provoking session. As a token of appreciation, I now invite Mr. P. Umar Khan to kindly come forward and present a memento to our esteemed chairpersons. I would like to request chairpersons also to join. Thank you everyone for your valuable contribution. It's my pleasure to introduce our next speaker, Dr. Indranil Chidalji, a distinguished clinician and researcher in audiology.
Chasing all the shadows, chasing you, diving through the darkness, coming through. Reach out and I'm praying for conviction.
Can I request Mrs. Vidya, faculty at APASLPA? Sorry. Can I request Mr. Srinivas sir and Mr. Sai Koti? Sir is from AYJ and Mr. Sai Koti is audiologist from PISHA to chair the sessions. Yes. And Dr. Indranil Chatterjee, he is the former General Secretary for ISHA 2017 to 20 and he has life memberships of several professional organizations. He has almost 21 years of work experience and he has guided more than 200 master's dissertation in audiology, speech language pathology, special education and dentistry. He has more than 120 publications in peer-reviewed index journals. He wrote several chapters in the book of audiology, speech language pathology, special education and otorhinolaryngology. He has achieved Manohar Memorial Awards for scientific presentations from ISHA in ISHA Con 2020 at Chandigarh. It's a pleasure to have you here, sir.
Put up the folder. So, good morning, all of you. Good morning, sir. My mentor, Rajasekhar sir, and other teachers are there here. My colleagues are there, and students, and the professionals here. As already in the morning session, Arun sir has told the sensory overloading, hyposensitivity, hypersensitivity, lot of issues, and I am facing also in my collaborative research that different sensory functions are really, it is improvising the communications things skills. So though my presentations, what has been given to me for, that is the childhood auditory processing disorder, but I focus on the discipline of auditory processing as such. Is a greater term. I am just focusing on auditory processing. Childhood is there because it is there, so I will cover a bit. And I will skip different slides, but I will definitely put some keywords so that any questions if you have, you ask me. That is number one. Number two, as already electrophysiological part has been covered, so little bit glimpses I will provide. And I have a software called Angel Sound. If anyone wants to learn from me, I will be there whole day. Here I cannot show you because itself it takes around 2.5 hours to understand the software. It is a big software I have with me. If anyone wants to learn auditory processing, so you can learn from me because I am there. It is there with me. So now coming to the overview, as you all know that our different lobes have different functions, and I think auditory processing goes to all the lobes and all the critical area of even cerebellum. That's why I have put at all the areas, frontal, parietal, occipital, cerebellum, brainstem, everywhere auditory processing occurs. Even our auditory physiology, when I was in master's student, auditory physiology means that we start from
cochlea, processing starts and ends up in the Hessel's gyrus, even the primary auditory area, secondary auditory area, lot of responses, the excitatory, inhibitory, there's the neurons, there are different cells, there are responses, Chopper's responses inhibitions, there are a lot of complicated electrophysiology. That time I was very little bit I understand. Nowadays time goes and then I have understood a bit of that. So auditory pathway, if you put auditory pathway, so I think those area you have to understand. And I am focusing nowadays my research focusing auditory processing not only in the case of the auditory processing disorders as such in the pure COPD. I take ANSD, I take hyperacusis, I take phonophobia, misophonia, I take tinnitus, I take cochlear implant patients to understand auditory processing disorders. Even for normal patients having different processing cues difficulties also we have to take. And I have already taken so many cases of ADHDs diagnosed for understanding what are the pathways actually is related to that. Quickly go to the auditory processing disorders, like it is already mentioned in the ASA side, that is a difficulties in auditory integration, organizing deficits, as all know. It is just a overview, phonetic decoding, auditory hypersensitivity as Sarah has told, and also prosodic difficulties. So this is basically auditory processing disorders as a whole. It's a holistic view if you understand. And to understand the auditory processing disorder, you have to understand, definitely you have to understand the cochlear maturations. So I have to start from maturations and how different traumatic exposure changes the brain functions, especially the higher level cortical functions in the different levels. So that's why there is a study I have found in the Lancet article. So there is a comparative study from rat and also with reference to the human. That study is very, very important. So we can also do the similar line of study to understand the CNS maturations using all those N400, P300, MMN responses, even acoustic change complex. So start with acoustic change complex, LLR, and finish it off with the P500. That is a new response is coming and the syntactic potentials. Also we can go for that. But it requires a lot of controlled setting. And we also know that auditory processing disorders means all those comorbidities may be there in the auditory processing disorder. Auditory processing disorder, it is there. But to understand auditory processing disorder, everything you have to tackle. So this is a spectrum of auditory processing difficulties. Auditory processing difficulties, spectrum disorders may be a beautiful term. Not only auditory processing disorder, directly you can tell auditory processing disorder means it is a disorder on the auditory processing. But there are a lot of comorbidities where auditory processing are affected, even in children. So I went through some literature things, some the meta-analysis and the reviews, and there is I have gotten ASA evidence maps, and ASA has given a lot of deliberate reviews in their sites with reference to how you can assess central auditory processing in children, in adults, in different comorbid conditions. And there are some, they have mentioned that central auditory processing, there is a phonemic processing and there is a linguistic processing. They have explained in the different laws. So there are some differential diagnosis of the processing itself. So that is also under the research, we have to do that. Okay, that is also another part, that what is the linguistic processing? Objective, subjective, what is the phonemic processing, objective, subjective, and how these processings are different in a different format of the responses. And also I have got that ASA has given that different terminologies, like what are the different difficulties they have faced, already we know, but it has been already, there is an SOP, the guidelines are there, how to go. And you see that some difficulties are there, and they have mentioned that difficulties are like that. In this way, you have to go for that. Even CAPD, there is one point term, CAPD is not due to multilingualism. There are a lot of people that are saying that their processing is delayed because a lot of family that, so that is discarded. Is not very true. So that is another part. I am not coming into this part. you all know these are the classical signs and symptoms of COPD, and even in children. So I just go beyond that, the ASHA guideline. We have studied some P300 responses in ADHD and MMN also, and got after therapy, there is a change of P300 responses with reference to latency and amplitudes of P300. So, and I will come there. So just it has been published in the International Journal of Audiology, and what we have found that in children also, in the learning disabled children and around 8 to 10 years of group, if you study with the P300, I have found that after giving therapy, that dyslexic children, the P300 amplitudes are improved, and latencies are also shortened. So that is also even same thing is there in the cases of tinnitus also. So I don't know what is the relationship with tinnitus also, same thing I have got, and same thing I have got in the case of the auditory processing. So this is also another aspect to look into. So this is the part I have got it through the some MOOC search, and got that hemispheric interactions is another part we have to take care of, and also working memory. And ASHA has given, American Academy of Audiology has given full-fledged aspects that how you will proceed. If you understand the subjective evaluations of the CAPD testing, how you have to go from case history, some audiological assessment, the basic assessment, peripheral central assessment, then auditory discrimination testing, temporal processing testing, dichotic testing, monoval low redundancy speech tests, binaural interaction tests. So all they have already mentioned. So I will just go to direct treatment part. Even in treatment, the goals are already set in this ASHA map, that how there are treatment approaches, mainly they are focusing on environmental modifications, direct skill remediations, and compensatory strategies. And I just go again forward. So I look into these two areas in my present research. One is a computer-based training to develop some certain apps, and certain instruments already available, how those instruments can be vividly used or robustly used for all those children to develop their communication skills. Interhemispheric transfer training skills, one Bailey's already has been mentioned, but how it should be provided to the instruments with the help of machine learning, that is another aspects, and also interlinguistic and other metacognitive strategies. So what are the genetics? So Indian Institute of Chemical Biology in Kolkata, we are now collaborating for one research that what are the genes and what is the audiological findings. In that way, I am testing the auditory processing in case of hearing impairment, in case of cochlear implant, tinnitus with the mild hearing loss, mild sensorineural hearing loss, and also children with dyslexia. That also we are taken care of. And the genetic testing means these genes, mostly FOXP2 and ROBO1, these two genes, they are catering. And so very soon we will start the work, because already the pilot phase we have already went through, and we have got the sample size also calculated. And also we take another genetic syndrome that is called fragile leg syndrome associated with autism spectrum disorder I have got. So already sample size calculation has been done. So after 1 year or 2 years, I will let you know what will be the status of my genetic research in the audiological part. So another important aspect is the overall aspects, understanding the therapeutic planning with the help of understanding of neuroplasticity and auditory learning. These two are very, very important. Neuroplasticity is from neurocognitive science, auditory learning from the psychological aspect. So these two are very, very facilitatory to provide impetus to understand auditory processing. So as we know, neuroplasticity is basically how brain's ability to change, adapt, and generate following neural injury, such as after stroke or traumatic brain injury, or any hindrances like autism, ADHD, anything. How the synaptogenesis takes place, how molecular synaptic things are there. Like one is a molecular level, that is called signaling pathways, how it is changed, and another cellular level. So these two can be understood by our work through learning modality. If you start with the auditory learning treatment and the pre and post, what is the change with the help of subjective test and validated by some objective tests like cortical potentials. So, and also we can classify the plasticity of or learning pedagogy with reference to structural and functional neuroplasticity. That is also another way of classifying neuroplasticity. So, the point is that we have to provide the basic aspects of learning. If classical conditioning, if you provide different therapy, there are a lot of therapies are there, series of therapies with reference to classical conditioning. Similarly for operant conditioning, similar for observational learning. There are a lot of therapeutic postulates are there. But what postulates are actually providing the vigorous impetus to the improvement aspects of the children with COPD, that is the important part. So that's why you have to understand the 4 aspects of learning pedagogy: descriptive pedagogy, explaining the environment, explaining the context, predictions, and with the control. So there are a lot of learning styles we know. Maybe somebody is very good auditory learner, somebody is very good visual learner, then other proprioceptive learner or mixed type of learner. So no, there are some dominant learners are there. There are some non-dominant learners also there in the system. So that's why there is one technique of associative learning we can also initiate. And associative learning means there are some stimulus or there are some different pedagogies are there. They are all detailing are there. So basically we can use visual format, auditory format, physical format, verbal format, logical, social and solitary format also. But we are mostly fixed with auditory and visual. Other parts are made by occupational therapists, physiotherapists, psychologists. But we can see what is the impact of all those learning pre and post using subjective and objective test in all those auditory processing categories. Auditory processing means not only childhood auditory processing disorder. Auditory processing means whoever comes with difficulties in auditory learning. That is the definitions what I am understanding of my different research. I just cut short all those approaches because it is there in my softwares and I am developing a softwares. Even Sarah has given those things. There is Williams 1 to 4 years, that pedagogy of the learning and musical stimulations also through auditory learning. So I am just not presenting all those things. But point is that yes, we have to understand properly auditory attentions or other mode of attentions, different hierarchical attention, dividing attention, sustainable attention, then alternating attentions, and how those attentions are reflecting on the working memory, sensory memory, episodic buffer in that way, and also what is the role of auditory cortex to integrate or summing up all those different stimulus in the level. So that is also an area. Even some book I have got, auditory verbal therapy is also used for auditory processing disorder for improvement. There is also 1 2 studies are there that auditory verbal therapy, the pedagogies are used for auditory processing disorders. The patients are the ADHD children or dyslexic children, ALD diagnosed children after 8 years. There is also studies are there. So what are the food for thought? So you have to start with some dedicated software that is only auditory processing studio is an AI based software because there are some softwares where different sensitivity and synthetic stimuluses are there, and you can also track how improvement is there after a particular time. That is also there. And also we know this is a very common software less. We must have, this is a common software. Everybody has this less software. But we have a very less knowledge on AI. AI means artificial intelligence, means machine learning, deep learning. So what we are using in one aspect that is called the narrow network learning, ANN, and that narrow network learning means there are some algorithms. Maybe it is a supervised algorithm, unsupervised or trainable algorithms. So what are the AI based rehabilitations? The tools we have got, lot of tools are there. Even the tools, see there are a lot of tools, AI assisted speech therapy tools, gamified tools, auditory training softwares, adaptive learning tools. You have a lot of remote monitoring AI tools. But one tool is already there, that is called brain-computer interface. Anyone has heard this name, brain-computer interface? Understood? Brain-computer interface. So, brain-computer interface basically, there is an electrodes, basically is an EEG, it is a cap that records some low volt stimulus for an amplified, pre-amplified, amplified, there is some things. It goes to the machine learning apps, and one machine learning assistant, like an AI assistant, he speaks. I can think I am a good boy. The assistant speak, I am a good boy. So, how? Because it is an EEG to speech converter. That is the point. So, it is the basics of the brain-computer interface. It is coming. And we as an audiologist, we can provide lot of different stimulus to augment all these things. Its application is not only restricted to audio processing disorder, but anyone having some communication difficulties, this can be worked as an alternative augmentative device tool. So this is another aspect. So I have software. So if anyone wants to learn from me, I have a software. So because there is a time gap, so I'll show you how those softwares are working actually. My work in my postdoc and my other part is restricted to the direct current stimulations and the repetitive transcranial magnetic stimulations, not only in direct auditory processing disorder, but in tinnitus and misophonia. And getting results, because I am getting at least 5-6 patients I have already done. We are tracking the results, is coming up, but definitely I have to prove those things in the APD also. So I am not going into the RMS into the details, but yes, this is the instrument, linear instruments what I am using in with the help of some psychiatric lab in the All India Institute of Medical Science in Kolkata. So what are the evidence-based practice? So starts with ma'am, Asha ma'am, it is there already. So everybody, we must do the work of Asha ma'am's work. That's CAPE. Daily routinely we are using our institute for any children with all those auditory processing difficulties. And I have one recorded aspects of co-modulation masking release. It has been published, and I have got a very good results in the dyslexia children utilizing the co-modulation stimulations to the dyslexic patients. Even ADHD, I have already told you that the ADHD, if you start PTN and MMN, after therapy, before therapy, there is a lot of changes in the P3 and the latency. It is shortened after therapy, and the amplitude also improves. With a short amplitude, it is improves. So that needs to be facilitated. That is actually the studies which I have published in different international and national platform. And latest I have used in the international journal, cochlear implant journal. That is an electrical SRT. We have measured using the reflex decay testing using one tympanometer in the contralateral, in the ipsilateral. That is the map, the current stimulations in the cochlear implant patients, and other part we are taking the latency from the impedance audiometry ESRT, and we are getting the effect of age and interventions with reference to ESRT. Not only the P300, M400, even you can start impedance audiometry to measure ESRT indirectly to understand the age and interventional age. That is another aspect. It has been just published in the Cochlear Implant International Journal. So in Kolkata, in Bengali, Oriya, Assamese, lot of things have been made for measuring auditory processing testing, the speech perception testing materials. But I think I should say we should have some group, nationwide group, so to at least publish one book for different language and different auditory processing disorders tool to be published in one book, so that it is being applicable to all of us, because so many Bengali patients are also coming to Hyderabad, but there is no tool. Bengali patients are going to everywhere. Even your Telugu patients are coming to Kolkata. So we don't have a tool to assess, ready-made tool. So if the materials have been published by some initiative has been taken place and it has been published in one book, all the materials with a copyright, so that this particular material can be used properly with a proper patenting and other IPR aspects, that legal aspects should be maintained. So thank you. If anyone wants to understand my softwares, whatever there, so you can directly meet me, so I will be available full day, so I can give you the support. Thank you.
Thank you very much, sir. I would like to request the chairs to shed the light on the topic.
Good morning, everyone. As Dr. Indira said rightly in the beginning of the session, that he is going to cover this APD as a whole, not a specific topic, and I am sure that he has stood by his words. I am really fortunate and honored to chair his session. He being my colleague in ARC and my friend. And when he was telling about the brain-computer interface, it reminded me of the recent Elon Musk experiments. He is successful in implanting one of the cases and read whatever they are thinking. And I would like to know whether this will have any implications on the cochlear implantations.
Sir, I have gone through a lot of literature such, but it is under the developing stage.
Right.
BCI is not very much widely applicable tool because of some issues with the, like you are thinking different and it is coming up. So a lot of other issues are there, legal issues are there. So those filtering is required. There are some different filters are coming up, the AI filters. If those are applicable in this particular generation of the BCI stimulus, sorry, the impulse, then only it can be available. Otherwise, there will be some legal aspects also.
Right. It's the topic is so vast, and the way he has handled it, really very delicate and very systematic, covering the past, present, and future. I was really fascinated about the research that he is presenting and the genetical research. I'm really looking forward to it. And now the session is open for the suggestions, questions, remarks from the audience.
Do you have any questions? Yes, sir, will be available here. You can meet sir during the lunchtime if you have any questions. With that, I thank Dr. Chatterjee for your clear and insightful presentation. Your experience has deepened our understanding of auditory processing in children and offered practical approaches for early diagnosis and intervention. Now, I request Mr. Srikanth to, as a token of appreciation, to kindly come forward and present a memento to our esteemed chairperson and Dr. Indranil Chatterjee.
Yeah, I just want to share something about Indranil. Okay, I've known him. When the photographer says look there, you should look there. I can right. Okay, so Indranil is another rising star from the East Coast. Okay, and he's got a lot of passion for research. Actually, see the number of publications that he has got, and also he is getting into the application part of it. See, most of us are theoretically based, right? Now there should be somebody who does, applications. Now he's into applications and he's willing to share the applications and then train you, or maybe, to understand. He says, I'm here today, so you can always come to me. It shows, that, he wants to empower everybody else. Okay. So I wish him all the best, Marin. God bless you. Right.
With that insightful session concluded, we have, before inviting the keynote speaker, we have a cultural event here now.
While you cross, I feel the breeze. Never to turn back into the sea, where you wait for me. Chasing you, diving into the darkness, coming through. It's next to nothing.
ఎవరు
I request all the participants to please be seated as our keynote speaker is here. I request all the participants to be seated as our keynote speaker is here.
heart, now you're mine. Here in the dark, with fireflies. Open your heart and feel the light. This before, never felt this before. Open your heart and feel the light. With fireflies. With fireflies. With fireflies. I've never felt like this before. I've never felt like this before. Open your heart and feel the light. With fireflies.
I request all the participants to please join us back.
Open your heart, now you're mine. Here in the dark, with fireflies. Open your heart and feel the light. I've never felt like this before. I've never felt like this before. Open your heart and feel the light. With fireflies.
Can I request all the participants to be back?
With fireflies.
We have a cultural event ready. I request everyone to join us back.
With fireflies. Open your heart, now you're mine. Here in the dark, with fireflies. Open your heart and feel the light. I've never felt like this before.
Request all students to come into the hall, please. All delegates are requested to come inside.
And feel the light. With fireflies. With fireflies.
Hello.
With fireflies.
Come on, all delegates inside. I want all delegates inside the hall, please. We are starting the inauguration. Delegates inside the hall, please. Later you can do your registrations. Get in.
To mark this special occasion, we'll have a traditional dance performance that beautifully reflect the rich cultural heritage of our host city, Guntur, the chilly city of India. I welcome.
कृष्णं कलय सखी सुन्दरं बालकृष्णं कलय सखी सुन्दरं कृष्णं कलय सखी सुन्दरं बालकृष्णं कलय सखी सुन्दरं कृष्णं कलय सखी सुन्दरं बालकृष्णं कलय सखी सुन्दरं कृष्णं सखी सुन्दरं बालकृष्णं 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 सखी कृष्णं विषय कृष्णं कृष्ण कृष्ण विषय कृष्णं सखी सुन्दरं कृष्णं सखी कृष्णं सखी
Then looks at the goods, then looks at the tax, then looks at the revenues. At the tax, then looks at the goods, then looks at the tax, then looks at the revenues. At the tax, then looks at the revenues. At the goods, then looks at the revenues. At the revenues. At the revenues.
Thank you very much for setting the stage with such a traditional and beautiful dance. Thank you so much. Now I would like to request Mr. Srikanth, audiologist from Visakhapatnam. He is the first audiologist in Andhra Pradesh region. I would like to request sir to address the APASLPA. Thank you.
Good morning, everybody. I think you had a very excellent three lectures from very renowned speakers. And now we have someone, I can't say better than them, equal to them. She is our keynote speaker. I welcome Dr. Vinjanampadu. She is the director of Lalita Hospitals. And and she is the Indian Stroke Association president. So she will be giving her key address today. Ma'am, actually, we wanted to have it in the inauguration session, but with the politicians, things can go bad. So we are having the keynote address now, and listening. Before that, I just wanted you to know, and also all our new delegates to know about our association. It was Sirisha who was instrumental in starting this association. We were very few. As she said, I am not the first one in Andhra Pradesh. It was giant Andhra Pradesh then. I think I am the fourth one in Andhra Pradesh. Earlier before us, there was one Manohar, Nandu, Suryanarayan Rao, and Varma. Fourth, I may be the fifth or sixth one, but in this 13 district, I am the first audiologist, qualified audiologist. I started my practice in Visakhapatnam. But it was Sirisha's idea that we should have an association. So we started the APA association in 2016, November 6th. So, of course, just like any other associations, we had starting problems. So there were very less numbers. We were only 30 in the beginning. Slowly it started increasing, and our population also increasing. Thanks to the work of the earlier associations, now almost every district in our state has a post. Though we are fighting for some of our rights, but number of posts, I think we are almost equal to Kerala. After Kerala, I think it is Andhra Pradesh, which has the post in almost every mandal levels, not only district levels, even almost every mandal levels. Now we have centers, early education centers and posts and speech therapy centers. Now even autism centers are coming. So it's all because of the works of the earlier these things. Sirisha and Rabba Mohan Kumar were the starters. Then Sri Lakshmi and Sridhar, they took over and they continued the work. They worked very hard, and then now we have Hari and our Gopi managing the whole distinct association. The young generation doing a lot of hard work for the faculty and our profession. So, of course, we have achieved some milestones. So now we have to achieve some more. Like I said, we got run behind people in the high offices for getting more posts. Now we are trying to get our nomenclature changed, and using some influence, we could get bilateral cochlear implant. Now under Audiologists we have the bilateral cochlear implant. Andhra Pradesh only has it. I think Kerala and one more state, Rajasthan, has it. Very few states have bilateral cochlear implant under Audiologists. Then we have a big occasion coming in 2027. We will be having the national conference for the first time in the Andhra Pradesh. For the first time in Andhra Pradesh, the national conference, Indian Speech and Hearing Association conference, will be held in Visakhapatnam. Our association is affiliated to ISHA, the national body. So with that, I request ma'am to come and give us, please.
my great honor to invite our keynote speaker, Dr. P. Vijaya, Director of Lalita Hospitals, Guntur, and the President of Indian Stroke Association to kindly come on. And she is a President of Indian Stroke Association, member of the opinion leader for ISHA Stroke Advisory Panel. She is the past president of AP Neuroscientists Association. She is a certified stroke assessor for primary and advanced stroke centers. She is the head of the department for neurosciences, Lalita Hospitals, Guntur. She is the director of Andhra Stroke Center, India's first QES accredited advanced stroke center. She won the Gold Winner Award for the World Stroke Organization for public stroke awareness camps. She is a winner of Diamond Status Awards, WSO Angels Initiative for Excellence in Stroke Care, and she has won the Best Teacher Award twice by ANBAI. She has won the Times Health Excellence Award 2023 titled Lesson in Neurology and Stroke Advocacy. She serves as a faculty for the DNB Neurology program and is a principal investigator for several landmark stroke trials with over 60 scientific publications and 4 book chapters to her credit. She has presented numerous scientific papers at prestigious international stroke conferences. Her most recent original research developed through international collaboration received the Paul Dudley White International Scholar Award at ISHA 2025. It's an honor to have you here, ma'am. I now request Ms. Sujita to present a token of appreciation. Please join me in extending a warm and enthusiastic round of applause. I would like to request ma'am to address the audience.
Thank you. First, I would like to thank the Association of AP Audiology and Speech Language Pathology Association and Sirisha particularly for insisting on my presence here. So I'm so happy to be here with you. And I also thank our esteemed faculty members from across India who made their time and effort to come here and inspire, not only educate, but also inspire our students. Thank you, sirs and madams, that you have come all the way. And then hello to all my colleagues and dear students and everybody. Today, I would like to share briefly some of my thoughts and perspectives because that is we are both are interconnected with our both sides of a coin, as they say. Clinicians are on one side and the rehab team is on the other side. Unless both are correct, that coin will not have any value. Similarly, the patient will not have the best benefit. So I'll talk to you about not only my perspective as the president of the national president of the Indian Stroke Association, but also as a senior neurologist and stroke specialist who has seen millions, thousands of stroke survivors and their caregivers. I've encountered their issues. And also as a friend of a mother of autistic child and daughter of a aging mother with sensory neural deafness. And mostly the most important impact, because yesterday only I lost my beloved teacher who has been inspired thousands of students. As a dedicated student of a teacher, great teacher who was muted with Parkinson disease. These are all the things that I have encountered in my life that will tell the story of what it is that you are doing and you can capable of and doing to the society. So as a stroke assessor and inspector all over India, and the most important point that they lack, the minus points wherever I get, you can switch that off. You can switch that off. Yeah, you did? Thank you. So whenever I go for inspection, it is not the doctors that are lacking. It is not the infrastructure that is lacking. It is the wherever I got the minus marks are for the swallow screen. That is an important aspect of a stroke center accreditation or certification. They always falter when they say swallow screen. So the sisters, the stroke nurses, the rehab team, especially the speech therapists and the occupational therapists is where most centers are lacking. This is the main issue. Though there is technology, advanced technology available now, methods available, evidence-based treatments available, the personnel are very less. Unfortunately, this is where the gap has been really huge and where it makes a difference. A small thing can make huge difference. And as a doctor who has treated thousands of patients, stroke treatment is in the acute phase, it's only 1 week, 2 weeks in the hospital. That is the easiest part. The challenges of the patients, they start when they go home. As we know, the challenges of day-to-day things, they cannot talk, they cannot communicate, they cannot swallow, they cannot take food or even water. In addition to the physical, all these things, the emotional trauma comes from the cognitive deficits. The speech and the hearing are intricately connected with the cognition. We are what we are. Humans are what we are because of our excellent brain. But that brain is what it is because of our language. The most important part of cognition and the connection is language. This is where we are apart from even the brightest animals cannot compete with us because of our language function. Language function automatically means cognition. It connects the various parts of the brain. It is the basis for memory, for everything higher up than this thing. Without language, nothing can be done. We are as dumb as any other animal. This is the most important connection that we have to. And luckily, there are so many treatments, as I was mentioning, and we are not able to harness those things. And the most important thing now is, as I was hearing from Sirisha, it seems there is not even a single college in Andhra Pradesh, in the state of Andhra Pradesh, for speech and audiology, which is very, very sad. Urgently, we need at least 10 colleges to take care of the requirement from the patients. Treatment is the most important part of a stroke rehabilitation is physical therapy and speech therapy. In fact, speech therapy comes first, as I told you, because that is where the patient will feel comfortable. Otherwise, they will become emotionally blunted, they get depressed, despaired, and they withdraw from the society. Without communication, soon it will lead to dementia. These days, global burden of neurological diseases is on the rise. According to the WHO, 1 in 3 people in the world are affected with a neurological disease, and half of them are debilitating, as we know. And the burden is 80% is borne by the low and middle income countries like us. 80% of the burden is in our countries, but the 80% of personnel are in the developed countries. This is a mismatch. We need them more, but the number is very less. And this is expected to grow even more. The burden is expected to grow even more because of the aging population that we are having. All the dementia, strokes, hearing deficits will be growing. And on the other hand, I think is audible? Everything is clear? I can hear me? Okay, nice. So the other hand, we have a lot of autism spectrum disorders which are coming up more and more now. As I was mentioning, my friend's son, she is a very bubbly, very active lady. Her son is autistic, and how it changes their entire family. You can see, entire family is affected by that effect. Their quality of life goes down, their things. And you can make him normal. That is the bright spot. You can make the child normal and then make a normal person in the society. This is where your role comes in again. And in addition to this, I was mentioning my teacher, who was many of us were inspired by him in the intermediate. He's a great scholar, multi-talented person. He is a scholar, he is an author, he is a painter, he is a cartoonist, he is everything. He has at least 10 things he used to do at the same time. That great man, Prabhulchala Samsaragar is his name. He was Telugu Pandit and teacher. We lost him yesterday with Parkinsonism. Fortunately or unfortunately, I was the person taking care of him for the last 10 years. And I know what went wrong with him. He was such a scholar, he cannot speak. He lost the ability to speak about 3 years back. And he lost the ability to swallow 1 year back. And now, towards the end, he really suffered a great thing with these day-to-day things. So and also the Parkinson disease is the commonest disease in our India, the degenerative disease, not Alzheimer's. Anyway, both are the suffering is same. In fact, the Parkinson patients are aware of their disease, which makes them even worse, and they are depressed, and the caregiver stress is into 10 times. All these diseases need your help. So this is a very, very important role of your this particular speciality, and we should be taking this important details, not only to the policy makers, where to increase the number of seats in the already existing places, increase the number of at least training centers in all the medical colleges. At least one thing will be there where they can train the people at least for a short term courses. And then many medical colleges, many audiology and speech colleges with all the facilities and good teachers, and so that we can give a community services as well. The entire stroke journey is after discharge, as I was mentioning. You need a rehab center with a physiotherapist, speech therapist, and occupational therapist, and a social worker in every district headquarters of Andhra Pradesh. How many districts are there? Now I think there are so many. 13 districts have become 26 or something. 23. So we need to at least 23 into 3 times. So this is the requirement. And I also congratulate all of you for taking up this profession. As Sirisha was somebody else was mentioning, you are our partners. You are the important part of the stroke team. The doctor, neurologist, physician, stroke nurse, and you all are all same. Because your job is equally important, if not more. If you cannot make the patient normal, there is no point. All of them will remain disabled and the family will suffer along with the patient. And one more thing that I want to tell you is, any work, any profession, is the passion is what matters. And human things, that any healthcare that matter, the commitment, the compassion, the connection, humaneness of us is what makes your patient happy. When you take up this profession, you be ready to have to handle that, the patient's emotional burden. How to lessen it. In addition to just doing your therapy, you also talk to them in a nice way, encourage them, and then this will take a long way in their recovery. And you also have to take care of the caregivers. You have to educate the caregivers how to take care of the patient. This aspect is very useful. You can also make them your partners in your treatment. Not only the physician on one side, you communicate with the physician and what is the cognition and what else we can do in that. It's a stroke team. We always have a multidisciplinary team meetings to, we always have a multidisciplinary team meetings for managing these stroke patients in our hospital. Every Saturday we used to have, and we are continuing to this as part of our stroke center accreditation, and in where we involve not only the neurologist but also the physiotherapist and speech therapist and the social workers. This is the actually stroke support groups. The other one I would like to request you is to form aphasia support groups. That is very useful again. It is a non-academic part, but in that way you can have more encouragement and involvement, inclusivity. As I like this, your theme, embracing diversity, advancing inclusive practices in the field of ASLP. This is where you can make a difference. You should have not only the academic part, but also the support groups. Aphasia support groups, at least 5-6 in the entire Andhra Pradesh, where they can have a social gatherings and they can share their stories. Stroke support groups, as you know, similarly, these aphasia support groups have a long way to go. The other point I would like to is the leverage technology. These days, in addition to our own efforts, there's so much technology that has developed. VR, virtual reality, all these tools you should adapt into your day-to-day practices to enhance your skills and the management. So I think these are all the points that I would like to share. And about my mom with sensory neural deafness, a simple ear thing can make so much difference. And without that, the communication goes down. There will be a lot of misunderstandings and there will be a lot of depressions and simple things. I know how much it makes a difference in the day-to-day life because I am seeing my mother with sensory neural deafness. Autistic children are really a big responsibility, not only of you, of the neurologists, of the pediatricians, of the society, to provide them with the proper care they need. They have the whole future ahead. We should never neglect these children. And as a society, we have that responsibility. The last thing is equity of care. Just because a person is living in Hyderabad, he has good speech therapy, and a person is living in Pidugurala, he doesn't have anything. That's what is not acceptable. As a elite society, we should be looking at this and thinking about it. Whatever the patient background or geographical location, he should be given the best available care. This is one thing which we should all work towards it. So I would like to once again thank Sirisha and team for giving me this opportunity, and I also call upon the policy makers and the society to reiterate the need and the role of the speech therapist and audiologist. Without you, our patients will remain mute. With you, with your help, they can talk, they can write, they can read, they can sing, and at last they will live again. The life after stroke is what matters, and you are an important part of this journey. I congratulate all of you for taking up this great profession, and I would like to commend all of you for the great work, and best wishes for your ongoing conference. Thank you all. Thank you so much.
Thank you very much, Dr. Vijaya, for your inspiring keynote address and for your continued leadership in healthcare and education. Your insights are valuable, ma'am. Thank you so much. Now I request.
I just wanted to give my comments about. Thank you, madam. I think you really spoke your heart out, and what distinguished your keynote from the usual keynote addresses that we have seen. People come with a PowerPoint, right? They come and present it. They talk everything what is going over the head. But you spoke from the real examples. Okay, you were talking about your friend's son, your mother, and also your teacher. So how it relates, how the neurological conditions can affecting the communication can affect not only the person but the whole family. Okay, so that I think perspective you really brought it out. So this is an exceptional keynote address that I have heard, and I really think it's one of the best because you were actually in sync or in resonance with what we go through in everyday day-to-day life. So all of us have to come together to bring succor to our patients, and you are doing a great job in stroke because I know my father had a stroke, and I know that he was a very respected teacher. Even now, his students remember him. But I know how the stroke, caused problem with his movement, with his speech. He had dysarthria. But even with that, he continued to teach also. So I can understand, the throes of the family and what contribution that you as a medical professional are doing and how we as a rehab people are doing. All of us come together for the benefit of the individual and society. Thank you very much for for your insight and also a candid address about how we can together do something about it. Give it a big round of applause, please. Thank you.
Now I would like to request Mrs. Sirisha, founder and president-elect, organizing chairman of conference, current president Mr. Harikishan Reddy, and secretary for APASLP Mr. Gopi Venkatesh to felicitate ma'am.
With fireflies. Open your heart, now you're mine. Here in the dark with fireflies. Open your heart and feel the light. I've never felt like this before. I've never felt like this before. Open your heart and feel the light. With fireflies. With fireflies. With fireflies. I've never felt like this before.
Now I would like to request Mr. Harikishan Reddy, president of APASLP, to felicitate Mr. Srinivas Rao, assistant professor of AYJ NIHH. Assistant Director of AVJ NIHH, Secunderabad. I would like to request Srikanth sir to join. I would like to request Ms. Suchita to join. Please join us with a round of applause.
మరి ఈనాటి ఈ ఆంధ్రప్రదేశ్ ఆడియాలజిస్ట్ అండ్ స్పీచ్ లాంగ్వేజ్ పెథాలజిస్ట్ అసోసియేషన్ కాన్ఫరెన్స్కి నన్ను ఒక ఆత్మీయ అతిథిగా, గౌరవ అతిథిగా కాదు ఆత్మీయ అతిథిగా ఆహ్వానించినందుకు నాకు ఇది ఎంతో ప్రత్యేకం, సంతోషం, గౌరవకారకం. అండ్ మీరు ఎంచుకున్న ఈ థీమ్ ఏదైతే ఉందో, ఎంబ్రేసింగ్ డైవర్సిటీ and including the practices, advancing the inclusive practices in the field of speech pathology and audiology అనేది ఈ కాలానికి ఎంతో సరిపోయేది. అంతేకాకుండా if we recollect the morning session by my friend Dr. Inil Chatterjee, where he has mentioned our India or Andhra Pradesh is linguistically, culturally, geographically, demographically very diverse, right? So we need to understand this, and he was telling that we need to have the materials which are rooted into our linguistic base and cultural base. Andhra Pradesh lone chuskunte we have various dialects. రైట్, వెన్ ఐ సే ఏమో మరి నాకు తెలియదండి అనే సేమ్ సెంటెన్స్ మనం ఒక శ్రీకాకుళం వెళ్తే ఏటి మరి నాకేటి తెలియదండి, రైట్. అదే మీరు రాయలసీమకి వెళ్ళినట్లయితే మీరు పుష్ప డైలాగులు చూసుకోవచ్చు. నేను ఎగ్జాక్ట్గా దాన్ని చేయలేకపోతున్నాను, మేబీ ఖాన్ సార్ ఈజ్ యాప్ట్ పర్సన్. సో ఆ విధంగా మనము మన కల్చరల్ బేస్కి తగ్గట్టు కూడా మన యొక్క థెరపీ టెక్నిక్స్ అనేది డివైజ్ చేసుకోవాల్సి ఉంటుంది. సో ఐఎమ్ షూర్ దట్ దీస్ ఇష్యూస్ విల్ బి అడ్రస్డ్ ఇన్ దిస్ కాన్ఫరెన్స్. అండ్ ఆంధ్రప్రదేశ్లో మరి డివైడ్ అయిన దగ్గర నుంచి కూడా మన ఆడియాలజీ అండ్ స్పీచ్ పెథాలజీకి సంబంధించి ఎన్నో ప్రోగ్రామ్స్ జరుగుతూ ఉన్నాయి, ఎన్నో డెవలప్మెంట్స్ చూసాము. మరి ఇంతకుముందు శ్రీకాంత్ సార్ చెప్పినట్లు దేర్ ఆర్ మండల్ లెవెల్స్లో కూడా గవర్నమెంట్ తరపున రిక్రూట్మెంట్స్ అనేవి బాగా జరిగాయి. స్పెషల్ ఎడ్యుకేషన్ తరపున అయితే కానీ ఐఈఆర్పీస్లో కానీ సో ట్రైనింగ్ ప్రోగ్రామ్స్ అనేది కండక్ట్ చేయడం కూడా జరుగుతూ ఉంది. అండ్ నేను రికాల్ చేసుకున్నట్లయితే శ్రీలక్ష్మి గారు ఒక మీటింగ్లో ఏదో చంద్రబాబు నాయుడు గారితో ఆటిజం గురించి క్వశ్చన్ అడిగినందుకే 2,000 కోట్లు పెట్టి ఆంధ్రప్రదేశ్లో పైలట్ బేసిస్ మీద సెంటర్స్ మరి స్టార్ట్ చేయబోతున్నారు. అండ్ నాకు ఇంకా కనపడే ఒకటే లోటు ఏంటయ్యా అంటే, ఇక్కడ మనకి ఆంధ్రప్రదేశ్లో 3 రీజన్స్లో అట్లీస్ట్ ఒక 3 స్పీచ్ అండ్ హియరింగ్ కాలేజెస్ అన్న గవర్నమెంట్ తరఫున స్టార్ట్ కావాలి. సో మరి నాకు ప్రీ కమిటెడ్ షెడ్యూల్ ఉండటం వల్ల తొందరగా వెళ్ళడం జరుగుతూ ఉంది. నేను ఇదే మన లోకల్ ఎమ్మెల్యే గారికి కూడా రిక్వెస్ట్ చేద్దాం అనుకున్నాను. సో మరి నా తరఫున అసోసియేషన్ వాళ్ళు దీన్ని తీసుకొని సో గట్టిగా ప్రయత్నం చేస్తే ఐఎమ్ షూర్ సో నెక్స్ట్ ఇయర్ బై దిస్ టైమ్ సో 3 కాలేజెస్ విల్ బి స్టార్టింగ్. మరి నాకు అవకాశం ఇచ్చిన అసోసియేషన్ ఆర్గనైజర్ సెక్రటరీ అండ్ పెద్దలు ఫల్గుని శ్రీకాంత్ గారు, అంతేకాకుండా హరి, సో whoever is instrumental in this program, so I am congratulating them as well as my sincere thanks to them for once again inviting me to this program. I wish a big and grand success to the program. Thank you, one and all.
Just wanted to endorse what Srinivas Garu spoke about, the need for speech and hearing colleges in Andhra. Okay, why I'm telling this because currently I'm the advisor for SRM University in Chennai, which also has a branch in Amravati. Okay, in Amravati they have only an engineering college and they want to convert it, they want to make it into a deemed university. So I have been asked to be an advisor because they have plans of starting a medical college and also allied health professions. So as an advisor, I'll be promoting and saying that you must first start a college of speech and hearing. So, ఈనాటి ఈ బంధము, whatever is my contribution, I will see that there will be a college of speech and hearing, NTR College of Speech and Hearing. Right? Okay. Thank you.
Thank you very much, sir.
సార్ ఇదే సందర్భంలో మేము అడుగుతున్నది ఏంటంటే యాజ్ ఎన్ఐహెచ్ సైడ్ నుంచి మీరు కూడా ప్రపోజల్ పంపించాలి సార్ సెంట్రల్ గవర్నమెంట్ కి, అలాగే ఆంధ్రప్రదేశ్ లో కూడా ఉండాలి అని చెప్పేసి.
Sure. Yes.
అవర్ సిన్సియర్ రిక్వెస్ట్ సార్.
Yeah.
Thank you very much, sir. Now I would like to request everyone to please be waiting as we are having an RCA video call now. All the participants are requested to be in the hall. I request all the participants to be in the hall as we have RCA video call now.
అది Sir, we are online. ఇక్కడ రావాలి కదా స్క్రీన్లో. మీ కెమెరా ఇటు తిప్పాలమ్మా, నీ కెమెరా. You have to turn the laptop this side for public. Yes. Sir, are we audible? నువ్వు మాట్లాడమ్మా. They should be audible. They are not audible.
ఆప్షన్స్ వచ్చి అది తీయకు, ఛార్జింగ్ స్విచ్, ఛార్జర్ తీసే అక్కడ దాకా రావద్దు.
దాంట్లో వస్తారమ్మా.
మాట్లాడండి.
హలో
సార్ అక్కడ మెసేజ్ ప్లీజ్ రెస్పాండ్ మై వాయిస్. ప్లీజ్ రెస్పాండ్ టు మై వాయిస్. Your voice is so very feeble. Can you please be a bit louder?
Are you able to listen me, ma'am?
Uh, People and the volume is on full. Can you please check that?
ఫోన్ కూడా ఆన్ చేస్తున్నా పట్టుకోండి.
Ma'am, are we audible? Hello? ఇప్పుడు మాట్లాడు.
Laptop. I was selected one. Laptop from off the screen.
Sir, we have turn the laptop. Turn the laptop.
ఉంచేమో అటు.
Sir,
Ma'am, please disconnect from the laptop, ma'am.
Disconnect from laptop. Disconnect from Sir, can you hear us now?
Yes, ma'am. Ma'am, is there anyone who can speak in Hindi, ma'am?
Sir?
Ma'am, is there anyone who can speak in Hindi, ma'am?
ముఖేష్ శ్రీ ఇంద్రగా మైక్ ఇంకో మైక్
ఇంకో మైక్. ముఖేష్.
audio బయటకు వస్తుంది.
లేదు అయిపోయింది.
Sir, another name.
मैम आपको मैम आवाज आ रही है मैम मेरी? Are you able to listen me, ma'am?
Yes, sir.
Ma'am, is there anyone who can speak in Hindi, ma'am?
मैं बात कर सकती हूँ सर हिंदी में.
ठीक है मैम. तो मैम आपको मैम मेरी आवाज अच्छे से आ रही है? मैं आपको प्रॉब्लम हो रही है सुनने में?
नहीं आ रही है सर अभी.
आ रही है मैम. तो मैम अपना फेस दिखा के बात करिए मैम. मैं पैसे बात उसके लिए कि मैम आपको सुनाई नहीं दे रहा मैम.
अभी आ रही है सर
मैम
मेरी.
हाँ मैम. रजिस्ट्रेशन में कितने स्टूडेंट्स का मैम यहाँ पे आपके यहाँ पे?
सर स्टूडेंट्स है सर.
मैम रजिस्ट्रेशन कितने स्टूडेंट्स का मैम? रजिस्ट्रेशन कितने पार्टिसिपेंट्स ने किया हुआ है?
50 students, 158 participants.
158 पार्टिसिपेंट्स ने रजिस्ट्रेशन किया हुआ मैम.
हाँ हाँ.
मैम कितने प्रेजेंट आज?
कितने present है? एक मिनट बोल रही हूँ सर अभी. एक मिनट दीजिए.
मैम फीस कितने ले रहा है पर पार्टिसिपेंट से?
फीस लिया है 1500 सर.
अकोमोडेशन है मैम इसके अंदर? ये विद अकोमोडेशन?
अकोमोडेशन के साथ 3000 सर. विदाउट
मतलब 1500. मतलब मैम 1500 और 1500 रुपये का पार्टिसिपेंट से वैसे ले रहे हैं पढ़ाने के?
हाँ सर.
मैम उसकी ज्यादा नहीं ले रहे आप?
विथ फूड और अकोमोडेशन सब कुछ है ना सर.
मैम अकोमोडेशन आप दिखा सकते हैं कि कैसा अकोमोडेशन आपका वहाँ पे? रूम दिखा सकते हैं आप?
रूम दिखाएं. हम लोग तो अभी हॉल में है सर. फोटो भेज सकते हैं.
हम रूम कहाँ पे है मैम? हम रूम कहाँ पे है मैम?
रूम यहाँ से 15 किलोमीटर दूर है सर। हमको बसेस
ओके, कोई बात नहीं मैम।
बसेस है, हम बसेस में
कोई
ले जा रहे हैं।
मैम प्रेजेंट कितने हैं वहाँ पे मैम?
प्रेजेंट कितने हैं? नंबर सर आप देख सकते हैं सभी को जो यहाँ अटेंड कर रहे हैं।
मैम टोटल 158 का रेशियो।
Sir, it's 183, sir.
और रजिस्ट्रेशन कितने का है मैम? रजिस्ट्रेशन बताइए आप।
टोटल रजिस्ट्रेशन 183 हुआ है, अभी 110 प्रेजेंट है सर।
183 का रजिस्ट्रेशन हुआ मैम।
स्टूडेंट्स
और 110 प्रेजेंट है।
40 स्टूडेंट्स है उसमें 183 में।
मैम प्रेजेंट कितने हैं?
110 प्रेजेंट है।
चेक कर लो। एब्सेंट कितने हैं मैम? एब्सेंट
सर 110 प्रोफेशनल्स प्रेजेंट है, 40 स्टूडेंट्स प्रेजेंट है।
मैम और स्टूडेंट्स की बताइए मैम। स्टूडेंट्स की बताइए बस।
स्टूडेंट्स 40 स्टूडेंट्स रजिस्टर्ड है, 40 स्टूडेंट्स
40 स्टूडेंट्स नहीं रजिस्टर किया होगा मैम।
40 सर 40
स्टूडेंट्स नहीं रजिस्टर किया होगा बस।
40 स्टूडेंट।
मैम हम ये कह रहे हैं कि 40 बच्चों ने ही रजिस्ट्रेशन किया हुआ बस।
बाकी सब डेलीगेट्स है सर जो प्रोफेशनल्स है। 110 प्रोफेशनल्स आए हुए हैं अभी।
और टोटल कितने हैं वहाँ पे?
पूरा टोटल यहाँ पे 150 लोग है।
पर्सन को हटा के बताइए मैम। रिसोर्स पर्सन को हटा के बताइए मैम। रिसोर्स पर्सन को हटा के बताइए।
रिसोर्स पर्सन के हटा के ही बोल रहे हैं सर।
कितने हैं मैम रिसोर्स पर्सन को हटा के?
रिसोर्स पर्सन को हटा के सारे 150 पीपल यहाँ पे प्रेजेंट है, जिसमें 40 बीएससी और एमएससी के स्टूडेंट्स है, बाकी सब प्रोफेशनल्स है। 110 प्रोफेशनल्स है।
मैम उन्होंने आरसीआई में रजिस्टर किया हुआ है बच्चे वाले लोगों ने?
हाँ प्री सीआरई रजिस्ट्रेशन हुआ है स्टूडेंट्स का, और बाकी सब ने आरसीआई में रजिस्टर किया हुआ है सीआरई में।
सीआरआर नंबर है मैम? सीआरआर नंबर है मैम उन सबका?
हाँ सर।
हम टोटल बताइए आपकी अटेंडेंस लिस्ट में कितने हैं मैम? अटेंडेंस लिस्ट में कितने हैं मैम?
अटेंडेंस लिस्ट आपको दिखा रही हूँ, ये है आपका ये है हमारा अटेंडेंस लिस्ट।
कितने हैं मैम? कितने हैं टोटल? कितने अटेंडेंस लिस्ट में?
150 आए हैं सर, जिसमें 40 स्टूडेंट है और 110 प्रोफेशनल्स है, जिसको सीआरआर नंबर है।
मैम हम ये पूछ रहे हैं आपसे, जो आपका अटेंडेंस लिस्ट है ना मैम, उसमें कितने अटेंडेंस लिस्ट में कितने पार्टिसिपेंट्स आपके? पार्टिसिपेंट्स
टोटली ऑफ 150
150 पार्टिसिपेंट्स ने रजिस्टर किया हुआ है, उसमें 110 आए हुए हैं जिसने सिग्नेचर किया है।
ठीक है मैम। एब्सेंट कितने हैं मैम? 40 एब्सेंट है?
40 एब्सेंट है सर।
ठीक है मैम।
ठीक है।
आप ये बताइए रिसोर्स पर्सन से मेरी बात कराइए।
रिसोर्स पर्सन इंद्रनील सर।
हेलो बोलिए बोलिए।
सर आपका नाम क्या है?
डॉक्टर इंद्रनील चटर्जी।
हाँ जी
डॉक्टर इंद्रनील चटर्जी मेरा नाम है।
सर आपका सीआरआर नंबर क्या है?
A05924।
तो टॉपिक क्या पढ़ा रहे हैं बच्चों को?
Topic differential diagnosis of autism in children.
सर कैमरे में देख के जवाब दीजिए सर। सर कैमरे में देख के जवाब दीजिए सर। कैमरे में देख के बताइए। बताइए टॉपिक बताइए।
Differential diagnosis of auditory neuropathy spectrum disorders in
ठीक है सर। मैम
यस सर बोलिए सर।
मैम सीआरई रोल दिखाइए नाम पूरा का पूरा। सीआरई रोल दिखाइए।
Hall, hall, hall.
पीछे जाइए हम सब साइड में जाइए मैम हम साइड में जाके फिर दिखाइए मैम क्या हुआ मैम अटेंडेंस लिस्ट दिखाइए मैम अटेंडेंस लिस्ट दिखाइए
Attendance list.
हाँ जी मैम दिखाइए कौन है
Share of service.
सर अच्छे से दिखाइए सर क्लियरली शो नहीं हो रहा सर क्लियरली शो नहीं हो रहा सर क्लियरली शो नहीं हो रहा मैम क्लियरली शो नहीं हो रहा मैम टेबल पे रखिए फिर दिखाइए मैम टेबल पे रखिए फिर दिखाइए
रिवर्स कंप्लीट
ये सर ब्लैक स्पेस को छोड़ा हुआ आपने सर साइन के बीच मैम
ये वाला सर एब्सेंट है सर अभी नहीं
सर ये पीछे जाइए सर जो एब्सेंट है ना सर जो एब्सेंट रेड पेन लेके उसके एब्सेंट मार्क करिए
Absent red pen से लिखिए, red pen लाइए, absent लिखेंगे। लिखेंगे सर। आपको लिखिए।
अभी लिखिए मैम अभी लिखिए मैम अभी लिखिए मैम कोई तो दिखाइए अभी लिख के दिखाइए
Absent.
Pen, pen.
Pen.
एब्सेंट लिखिए मैम ABSENT प्रॉपर लिखिए मैम
Students. Yeah. Student. Absent. Red pen, red pen. Pen, pen.
हेलो
दे दो स्टूडेंट्स के
इसको 35 135
पेन 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 ఇంకో పెన్ తెచ్చుకోండి ఒక నిమిషం మీకు ఎలాగో పాయింట్స్
अरे 74 उससे 2.0
मैम मैम
वाईफाई से कनेक्ट मैं वाईफाई से कनेक्टेड है आपका वहां पे कब देख
This is absent.
ma'am
Circulating it, sir.
ma'am is there any Wi-Fi in your CRE hall ma'am
Sir, I can't hear you. सुनाई नहीं दे रहा है.
ma'am is there any Wi-Fi in your CRE hall ma'am
CRE?
ma'am is there a Wi-Fi in your CRE hall ma'am Wi-Fi है आपके CRE
सर
ma'am I'm asking that कि CRE hall में Wi-Fi है आपके यहाँ पे अब सीधे तक चेक हो जाएगा एक महीने तक नहीं
Please maintain silence. We can't hear. अभी बोलिए सर।
मैम हम पूछ रहे हैं कि वाईफाई है आपके सीआरई हॉल में?
सीआरई अभी चल रहा है ना सर?
मैम वाईफाई है, वाईफाई वाईफाई मैम नेटवर्क मैम थोड़ा प्रॉपर नेटवर्क कनेक्शन करिए मैम। आपसे हम वीडियो काफी ब्लड आ रही है।
Wi-Fi is not there. Sir. Lag is there.
मैम कुछ भी करिए मैम, पर नेटवर्क अच्छा करिए मैम।
ओके ठीक है।
सुपर
दिख रहा है सर अभी? अभी आपको स्क्रीन दिख रहा है हमारा?
मैम ब्लड आ रही है मैम, अभी भी मैम ब्लड आ रही है मैम।
మ్యామ్
బ్లడ్ ఆ రही है।
అక్కడ లైన్ సార్
బ్లడ్ వస్తుందంటే మనం ఏం చేయగలుగుతాం దానికి?
అందుకని ఇంకేం చేస్తాం
मैम मैम एक काम करते हैं मैम।
हाँ बोलिए सर।
मैम एक काम करते हैं मैम।
हाँ
बता दीजिए आप मेरे को, ठीक है?
आपकी आवाज कट रही है, आप फिर से बोल सकते हो?
मैम मेरे को बता दीजिए रजिस्ट्रेशन कितने बच्चों ने किया, प्रेजेंट बता दीजिए और एब्सेंट बता दीजिए फिर से दोबारा से।
रजिस्ट्रेशन कितने किया है?
ఫస్ట్ డెలిగేట్స్ చెప్పండి
पहले स्टूडेंट्स का बताएं, प्री सीआरई जिसका है।
नहीं नहीं मैम टोटल बताइए। 150 बताया था ना आपने मैम, रजिस्ट्रेशन 150 बताया था ना आपने?
158 सर।
आपने 150 बताया था हम थोड़ी देर पहले।
देख हाँ जी, बात यह है कि हमारे पास पूरा लिस्ट पड़ा है पर उसमें सीरियल नंबर नहीं है, तो इसीलिए काउंट करने में हमें थोड़ा टाइम लग रहा है। बस यही
सर साइन कितने बच्चों ने किया सर?
वो हम 2 मिनट दे दीजिए, मैं काउंट करके बताता हूँ आपको, ठीक है?
सर साइन करके बताइए कि किस किन बच्चों ने साइन किया है, ठीक है सर?
ठीक
वो लिख के वो होगी सर।
ठीक है जी, 2 मिनट दीजिए बस।
सर फटाफट करिए से क्योंकि लंच स्टार्ट होने वाला है थोड़ी देर में हमारे भी।
ठीक है जी, समझ आ गया।
Forty-three or 7 sir.
There a total of 43 students are present here in the class in the conference right now.
There are 43 students present.
हाँ जी. आप
सर
हाँ जी.
सर साइन कितने बच्चों ने किया? सर साइन कितने पार्टिसिपेंट ने साइन किया सर?
साइन
साइन
43
किया
लोगों
ही
ने साइन
43
किया
है आपको दिखा रहे हैं
count कर
देखिए
सकते हैं. आप देख लीजिए.
ये देखिए साइन
कितने बच्चों ने साइन किया मैम? काउंटिंग करके बता सकते हैं आप?
43 बच्चों ने साइन किया पूरा लिस्ट में.
सर और रजिस्ट्रेशन सर कितने बच्चों ने किया? टोटल रजिस्ट्रेशन बताइए.
पूरा रजिस्ट्रेशन
45 3 absent
Total 46 people registered and 43 are present here right now.
And 3 are absent.
हाँ जी हाँ जी 3 absent है.
ये जो 3 absent है उनका नाम बता सकते हैं आप?
हाँ जी. एक
बताइए.
शेख सीमा ताज
मैम सीआरआर नंबर?
No, they are students.
स्टूडेंट्स
मैम सीआरआर नंबर नहीं है क्या मैम उनका?
वो प्री सीआरआर क्या है ना सर उनको सीआरआर नंबर तो नहीं आया है.
अरे मैम जिनका सीआरआर नंबर है उनका पूछ रहा हूँ मैं. मैम क्यों कंफ्यूज कर रहे हैं मैम आप मुझे?
సిఆర్ఆర్ నంబర్ ఉన్న వాళ్ళు ఎవరెవరు అబ్సెంట్ చెప్పండి.
7 absent, sir.
7 ఆర్ అబ్సెంట్. ఐ విల్ టెల్ యూ ద నేమ్స్.
total number
जिसको सीआरआर नंबर
total 129 members.
हाँ जी मैम बताइए.
A46178 रोजा साले इज एब्सेंट.
एक सेकंड मैम आराम से
A46178
A46178.
हाँ. Then another person is
मेरे लिस्ट में मैम है ही नहीं मैम.
हाँ
मैम ये मेरे लिस्ट में सीआरआर नंबर नहीं है मैम.
सीआरआर नंबर नहीं है.
मैम
रोजा साले हर नेम इज
बताइए मैम.
दूसरा नंबर बता रही हूँ जो एब्सेंट है.
मेरे गेस्ट के नहीं
प्रेम लता 52526 शी इज एब्सेंट. 5
ये कुछ तो होगा मैम.
हाँ A52526 526 she is absent. Her name is Prem Lata.
मेरी लिस्ट में नहीं है मैम. कौन सी लिस्ट बता रही है मैम?
Attendance list of students.
प्रोफेशनल्स लिस्ट है सर ये. सीआरआर नंबर जिनको है.
ये आपके अटेंडेंस लिस्ट में है मैम ये?
हाँ बच्चों को सीआरआर नंबर नहीं है स्टूडेंट्स का किसी का भी. सभी ने प्री सीआरई किया है उनको नंबर नहीं आया है. जो
Wait a second,
प्रोफेशनल्स
wait a
है उनका
second.
नंबर बोल रही हूँ.
వెయిట్ అ సెకండ్ మ్యామ్.
యా
లిస్ట్ లో మాకు వేరే లిస్ట్ అని చెప్పండి. ఈ లిస్ట్ ఆ లిస్ట్ ఒకటే అనుకుంటున్నాడు ఇందాక నుంచి చచ్చిపోతుంది అనుకేదో. ఈ లిస్ట్ అటెండెన్స్ చూపిస్తే మీరు ఆ లిస్ట్ ఎందుకు చూపిస్తున్నారని ఫీల్ అవుతున్నారు ఇందాక నుంచి.
एक సెకండ్ అంటున్నాడు ఆయన ఏదో చూస్తా. మరి అందుకే రావు. హలో
అయిపోయింది లంచ్ బ్రేక్ వెళ్ళిపోయారు.
మ్యూట్ చేశాడు ఆయన. ఏం అడుగుతున్నాడు ఏమో చేస్తా. పట్టుకో. నీకు హిందీ వస్తుంది కదా.
हाँ जी बताओ.
मैम नेक्स्ट क्वेश्चन बताइए सर।
क्या आप थोड़ा आराम से बात कर सकते हो, आपका आवाज कट रहा है बीच बीच में।
नेक्स्ट क्वेश्चन बताइए सर, नेक्स्ट क्वेश्चन बताइए।
नेक्स्ट पर्सन, अच्छा ठीक है, एक सेकंड रुक जाइए। एब्सेंट, हाँ। A60636 देवरकोंडा रुचिता।
वेट अ सेकंड सर। ए
60636
देवरकोंडा रुचिता। ठीक है, नेक्स्ट।
हाँ जी, नेक्स्ट A41921
A41921
41921 राघवेंद्र। अच्छा एक सेकंड रुक जाइए।
नेक्स्ट
हाँ जी एक सेकंड रुक जाइए, इन्होंने बस साइन करना भूल गया, ये अभी है, आपको दिखा सकता हूँ, एक सेकंड ना, क्या लेना।
मेरी बात करिए।
हाँ जी इधर ही है, बस इन्होंने साइन नहीं किया है। ठीक है जी, नंबर చెప్పండి।
సిఆర్ఆర్ నంబర్ అండి।
A41921।
अभी ये है पर अभी ये यहीं पर है, पर इन्होंने साइन नहीं किया है। ठीक है जी
सर, मेरी उनसे बात कराइए। बात
हाँ जी एक सेकंड
मेरी उनसे बात कराइए।
మాట్లాడండి।
हेलो,
आपका नाम क्या है?
राघवेंद्र मार्कोला।
जीमेल आईडी
raghu.marka50@gmail.com।
फोन नंबर
9493558123।
एक सेकंड रुकिए आप। सीआरएल नंबर दोबारा बताइए।
कौन सा?
सीआरएल नंबर दोबारा से बताइए।
A41921।
फादर्स नेम
फादर्स नेम सूर्यनारायण गौड।
एड्रेस, परमानेंट एड्रेस।
मंचिरियल, तेलंगाना।
परमानेंट एड्रेस बताइए।
हाउस नंबर 1-14-346/A, बालाजी नगर, सिरपुर, कागज नगर, 50429।
एजुकेशन
बैचलर ऑफ ऑडियोलॉजी, BASLP।
कौन से ईयर में पास आउट हैं आप?
2014।
ठीक है, आपने साइन कर दीजिए आप अपना।
एक सेकंड। ठीक है जी, वो साइन कर रहा है अभी।
ठीक है, करिए।
ठीक है जी,
नेक्स्ट पर्सन जो एब्सेंट है।
నెక్స్ట్ అక్కడే ఉన్నారు కింద ఉన్నారండి। A53749 53749 749।
हाँ जी, श्रीकांत।
All students who have CRR number, please come forward. Please come here.
एक सेकंड रुक जाइए, वो
They are coming here.
एक सेकंड रुक जाइए, बस वो आ रहा है।
सर अभी बताइए मत, अभी बस उनके बता टोटल कितने हैं? टोटल नंबर बता दीजिए आप मेरे को, अभी बताइए मत।
पांच है, 5 बच्चे हैं जिनके पास CRR नंबर है।
They are MSc students.
आपके पूरे उसमें सीआरआर नंबर खाली 5 बच्चों के पास ही है?
हाँ जी, क्योंकि वो MSc स्टूडेंट्स है, बाकी सब BSc के स्टूडेंट्स है।
तो BSc स्टूडेंट्स का सीआरआर नंबर नहीं है?
नहीं है जी।
तो जो 5 स्टूडेंट हैं जिनके
क्या जी
बताइए,
पांचों का नाम
जो हाँ, 5 का नाम और सीआरआर नंबर।
Your name CRN.
A67689। आराम से, धीरे से बोल।
आराम से।
A67689।
A67689।
A67689। Was it audible?
एक मिनट रुकिए, मैं चेक कर रहा हूँ।
हाँ जी ठीक है जी।
इनका नाम ही है लिस्ट में।
नाम बता दीजिए।
अभिलाष पति।
सर आपका सीआरएल नंबर ही नहीं है लिस्ट में सर हमारे डिवाइड लिस्ट में।
आप बताओ फिर से। 867689।
एक काम करते हैं,
हाँ जी।
एक काम करते हैं, सुनिए
हाँ जी बताइए।
अभी लंच करते हैं,
हाँ जी
ठीक है?
ठीक है जी।
2:30 के अराउंड वापस से आपके वो करते हैं, ठीक है?
अब अभी अभी ठीक है, आप लंच करके 2:30 पे कॉल कर लीजिए।
दूसरा कॉल नहीं करेंगे, आप कनेक्टेड रहिए, ठीक है? कनेक्टेड रहिए,
अभी
आप
मतलब
अपना कैमरा ऑफ कर दीजिए।
एक बात यह है कि हमारे फोन में कनेक्टेड है और फोन में चार्ज नहीं है। हाँ जी आप बात कर लो।
फोन को कनेक्टेड रखिए, फोन चार्ज कर लीजिए आप।
He will have lunch and come back.
Okay.
We have to wait till that time. So he will have lunch and come back at 2:30. Okay, we'll keep it connected. Fine.
Listen ma'am, ma'am, listen ma'am. आप फोन कनेक्ट कर लीजिए चार्जर में, ठीक है? और आप कनेक्टेड रहिए बस, ठीक है?
ठीक है
और
सर।
लीव मत करिए, जब हम बुलाएंगे तब आप आ जाइए।
ठीक है, कितने बजे आप आ जाएंगे ऑनलाइन? हम भी लंच को ब्रेक कर रहे हैं, सो हम सबको फर्स्ट
आपका मैम लंच ब्रेक कितने बजे तक ओवर होगा? लंच ब्रेक कितने बजे तक ओवर होगा आपका?
क्या जी?
तो हम लोग अभी ऑनलाइन कनेक्टेड हैं आप लोगों से।
हाँ सर कनेक्टेड रहिए आप, बस ये बताइए लंच ब्रेक कितने बजे ओवर होगा आपका?
आप बस इतना बता दीजिए कि आपको 2:30 पे क्या क्या चाहिए होगा कि हम रेडी रखेंगे कि जल्दी खत्म हो जाए काम।
सर मेरी बात सुनिए, 2:30 पे मैं बच्चों का नाम बोलूंगा,
పెట్టేస్తున్నాము ఎందుకంటే కింద హాల్ రెడీ మనకి హాల్ 2 o'clock రెడీ అవుతుంది
onto the stage. Mr. M.S. Srikanth to give his valuable speech.
Good afternoon, everybody. Sorry for the delay in the inauguration program. Due to unforeseen circumstances, we had to delay this thing. So we have our guest of honor, Dr. Koya Subbarao Garu, Chairman of KKR and KSR Institute of Technology and Sciences, and Dr. Rajshekhar, former Dean, Manipal Hospital, consultant to so many institutions, and our well-wisher, and డాక్టర్ ఉమర్ ఖాన్ గారు, ఈజ్ ఫౌండర్ ఆఫ్ హెలెన్ కెల్లర్ ఇన్స్టిట్యూట్. దెన్ డాక్టర్ ప్రేమలత, మా ట్రిపుల్ ఏ అంటాం. ట్రిపుల్ ఏ అంటే మనకి అకాడమిక్ ఆపద్ బంధు. మాకు మన ఏపీలో తెలంగాణలో ఎవరికి ఏమి అకాడమిక్లో ఏం కావాలన్నా. సో డాక్టర్ అపర్ణ గారు, శిరీష గారు, హరికృష్ణ గారు, ప్రెసిడెంట్ అండ్ ప్రెసిడెంట్ ఎలెక్ట్ ఆఫ్ అవర్ అసోసియేషన్. సో అసోసియేషన్ గురించి ఆల్రెడీ నేను చెప్పాను ఒకసారి, జస్ట్ రిపీట్ చేస్తున్నాను. మనం 2016లో శిరీష గారు చొరవ తీసుకుని మన అసోసియేషన్ని స్టార్ట్ చేశారు. అప్పుడు ఓన్లీ మనం 30 మంది ఉండేవాళ్ళం. ఇప్పుడు దగ్గర మన 200 మంది దాటాం, 210. ఇవాళ కూడా కొంతమంది అసోసియేషన్ జాయిన్ అయ్యారు. సో 210 దాకా మనం జాయిన్ అయ్యాము. శిరీష గారు స్టార్ట్ చేసినప్పుడు ఆవిడతో పాటు మన రెబ్బా మోహన్ కుమార్ గారు సెక్రటరీగా ఉండి, బోత్ ఆఫ్ దెమ్ హ్యావ్ పుట్ ఇన్ ద ఎఫర్ట్ టు స్టార్ట్. ఆ తర్వాత మన శ్రీధర్ గారు, తర్వాత శ్రీలక్ష్మి మేడం దాన్ని బాగా ముందుకు తీసుకొచ్చారు. దే డిడ్ అ లాట్ ఆఫ్ వర్క్. ఆ తర్వాత ఇప్పుడు ప్రస్తుతం మనకి హరికృష్ణ అండ్ గోపి ఆర్ ఆల్సో కంటిన్యూయింగ్ ద గుడ్ వర్క్. సో దిస్ అసోసియేషన్ ఈజ్ నౌ ఫ్లరిషింగ్, బట్ దెర్ ఆర్ లాట్ ఆఫ్ రోడ్ బ్లాక్స్. మనం అది క్రాస్ చేయాలి. సో దాని గురించి అందరూ కష్టపడుతున్నారు. గవర్నమెంట్ ఇన్స్టిట్యూషన్స్ అన్ని అప్రోచ్ అవుతున్నాం. మన దగ్గర ఈ మొత్తం జిల్లాలో ఒక కాలేజ్ కూడా లేదు. మనకి కాలేజ్ పెడితే బాగుంటుందని చెప్పేసి అందరూ కూడా రిప్రజెంట్ చేస్తున్నారు. మనకి హ్యూమన్ రిసోర్సెస్ అవసరం చాలా ఉంది మన ఫీల్డ్లో. సో అది దానివల్ల మనం కాలేజ్ గురించి కష్టపడాలి. చాలా డెవలప్మెంట్స్ జరిగాయి, బట్ ఇంకా జరగవలసి ఉంది. సో అఫ్ కోర్స్ ఎవ్రీథింగ్ విల్ నీడ్ టైం. కొద్దిగా మనందరూ కలిసి ఒగ్గట్టుగా మనం కష్టపడితే వీ కెన్ అచీవ్ థింగ్స్. మీరు ఇప్పుడిప్పుడే చూశారు మనకి ఆర్సీఏ ఎంత ట్రబుల్ ఇస్తుంది అని. సో మనం కూడా వీ షుడ్ ప్లాన్ టు హ్యావ్ అవర్ ఓన్ అసోసియేషన్, ఆర్ వీ షుడ్ జాయిన్ ద అసోసియేషన్ వేర్ ద ఫిజియోథెరపిస్ట్ అండ్ ఆక్యుపేషనల్ థెరపిస్ట్ ఆర్ దేర్. దాని గురించి ఆల్రెడీ ఇప్పుడు ఈ పెద్దలందరూ మాట్లాడుతున్నారు. మన అసోసియేషన్ ద్వారా కూడా మేము ట్రై చేస్తామని హామీ ఇస్తున్నాను. మనందరూ వెళ్ళి ట్రై చేసి త్రూ ఈషా అండ్ త్రూ అదర్ దిస్ థింగ్ మనం ఎలాగైనా ఈ ఆర్సీఐ ట్రబుల్ నుంచి తప్పించుకోవాలి. అది ఒకటి మనకి అవసరం. సో అది దాని మీద కూడా మనం వర్క్ చేస్తున్నాం. సో మన ఫీల్డ్ బాగా ఎదుగుతుంది. ఇంతకుముందు ఆంధ్రాలో ఎక్కడ 5-6 ఉండేవారు క్వాలిఫైడ్ పర్సన్స్. ఇప్పుడు ప్రతి మండలంలో ప్రతి జిల్లాలో ఉన్నారు. అది కాకుండా దగ్గర 15 కాక్లియర్ ఇంప్లాంట్ సెంటర్స్ ఉన్నాయి ఇప్పుడు ఆంధ్రప్రదేశ్లో. బయోలాటరల్ సిఐ అవుతున్నాయి. బట్ కాలేజ్ ఒకటి మనకి తక్కువగా ఉంది. అది కాకుండా కొన్ని ప్రాబ్లమ్స్ ఉన్నాయి. మన ప్యానల్ డిస్కషన్లో ఇవాళ ఆ ప్రాబ్లమ్స్ కూడా డిస్కస్ చేస్తాం. మనం ఆ ప్రాబ్లమ్స్ని ఎలా సాల్వ్ చేయగలము, మనమే మనం ఎలాగ హెల్ప్ చేసుకోగలము. మనకి ఎవరు సహాయం చేయరు, మనమే పరిగెత్తాలి, మనమే కష్టపడాలి. సో మనం గవర్నమెంట్ని కొద్దిగా ఫ్రీక్వెంట్గా అప్రోచ్ అయ్యి మన ప్రాబ్లమ్స్ చెప్పుకొని మనం ఎలాగ ఇంప్రూవ్ చేసుకోవాలనేది కూడా మన ప్యానల్ డిస్కషన్ చేసుకుంటా. ఎనీవే ఇవాళ వచ్చిన స్టేజ్ మీద ఉన్న అందరికీ నా వందనాలు తెలుపుకుని ముందుగా సుబ్బారావు సార్ని ఆయన స్పీచ్ ఇవ్వగలను.
గుడ్ ఆఫ్టర్నూన్. కాన్ఫరెన్స్కి వచ్చేసినటువంటి వేదిక మీద ఉన్నటువంటి పెద్దలకి, ఎందుకంటే వీళ్ళందరూ నాకు పెద్ద పరిచయం లేదు, అంటే అలాగే అందరికి కూడా నమస్సుమంజలి. ఏదైనా ఒక ఆర్గనైజేషన్ స్టార్ట్ చేయటం చాలా ఈజీ, ఆర్గనైజేషన్ గ్రో చేయటం చాలా కష్టం. అంటే 30 మెంబర్స్తో స్టార్ట్ చేసినటువంటి ఆర్గనైజేషన్ ఇవాళ 210 మంది వరకు వెళ్ళటం, ఇంకా రాబోయే రోజుల్లో మిగతా ఆర్గనైజేషన్స్ని కలుపుకొని ఇంకా భారీ ఎత్తున చేయటానికి ఉన్నందుకు సంతోషిస్తూ, కొత్తగా ఎలక్ట్ అయినటువంటి ప్రెసిడెంట్ని అభినందిస్తూ, మీ కాన్ఫరెన్స్ సక్సెస్ అవ్వాలని, మా నుంచి ఏదైనా సహాయ సహకారాలు, అంటే నాతో వీళ్ళు ఇంటరాక్ట్ అయినప్పుడు చెప్పింది ఏంటంటే కాలేజెస్ లేవు అని. కొంచెం ఆలోచిస్తున్నాం, అటువంటిది ఏమన్నా మా వల్ల ఏమన్నా ఏర్పాటు చేయడానికి వీలవుతుందని. ఎందుకంటే ఐఎమ్ హ్యావింగ్ 2 ఇంజనీరింగ్ కాలేజెస్. అటువంటిది చేయటానికి ఆస్కారం ఉండిద్దామని అనేది ఒక ఫీడ్బ్యాక్ తీసుకొని ఒకవేళ అటువంటి అవకాశం ఉంటే ఖచ్చితంగా, ఎందుకంటే సమాజానికి ఉపయోగపడే పని. ఎందుకంటే వీళ్ళలో మన చాలా మందికి మాటలు రాని వాళ్ళకి కానీ, లేకపోతే ఏదైనా ప్రాబ్లం ఉండడం వల్లనే మనం ముందుకు తీసుకురాగలుగుతున్నారు. అది అది యాక్చువల్గా ఒక రకంగా మనం కమర్షియల్గా అయినప్పటికీ సేవ చేసినట్టే. కాబట్టి అటువంటిది ఆలోచన కరెక్ట్గా ఉంటే చేయటానికి ముందుకు వస్తానని తెలియజేస్తూ, మరి ముఖ్యంగా నన్ను ఇన్వైట్ చేసినందుకు శిరీష గారికి, ఆ టీం మొత్తానికి కూడా ధన్యవాదాలు తెలియజేస్తూ సెలవు తీసుకున్నాను. థ్యాంక్ వెరీ మచ్.
I just have to mention one thing. Mr. Subbarao, with his kind heart, he has given this venue and buses free for us for this conference. You should give him a big hand.
Thank you very much, sir. Now I would like to request Rashekar sir to give his speech.
Namaskaram, good afternoon, respected Subbarao Garu, and all the dignitaries and my colleagues who are on the stage, and as well as all the delegates and my good friends. It's for me a great honor to be here. You know, I have been a part of the AP, right? Andhra Pradesh State Association, invited, uninvited. Okay, I've been a part of it. In fact, you know, I attended the one in Vijayawada, then I went to Vizag. I've again come back here. Okay, I'm so very happy to be here. This conference is a significant milestone in that we are not only coming together as speech and hearing professionals, but also to learn. There is advancement of our profession. Because the day you stop learning, you cease to exist. Every day, new things are being added up, and we have to keep ourselves abreast. If you want to be a thorough professional, you have to learn every day. Though it's more than 45 years that, you know, I have left All India Institute of Speech and Hearing as a postgraduate student, I still feel that what I've learned is nothing. I still keep learning every day. So this is an opportunity for you. So this conference is mainly focusing on bringing all professionals in the state together, and also to get the best of resource persons from across the country, so that, you know, you have their expertise and their experience on a platter. So all the delegates, you should be really blessed that, you know, you have best of resource persons. You already had 3 lectures, very useful, and, you know, state of the art. What is relevant in today's clinical practice is being discussed. And also we have many more to come in the afternoon and also tomorrow. So this is for you, giving something on a platter for you. Okay, so I'm very happy to see that most of the delegates are inside the hall, because many conferences I have gone, many of the delegates are all outstanding. They'll be standing outside the hall, chit-chatting, drinking coffee, tea, and saying, you know, sightseeing undakada, where can I go? Pushpa number 2, ye theater lundu, I want to go and see. But here I've seen most of you are inside. That again speaks about the seriousness of this conference and that you have come here to learn. So I think that's a big thing. As Subbarao Garu rightly said, to start something is not difficult, easy, but to sustain it is very difficult. So starting off with just a paltry 30 number to today what it is growing. I think big hats off to Srisha Garu. Give her a big round of applause. And also the other torch bearers of the Andhra Pradesh, Sridhar Garu or Lakshmi Garu or anybody who has been with the organization. And of course, Srikant is like a Bhishma Garu. So he's always there, like Bhishmacharya, right? Guiding, goading, okay, chiding. So all that he does anyway, but in the interest of the organization. So I'm extremely happy to be here, a part of you. The only thing which is amiss or which, you know, causes irritation is, you know, of course, the interruption by the statutory body, because they are regulatory body and statutory. You know, we have no other go than to abide by. But I think, you know, it's high time that this stops. They should not come and disturb in a scientific program, you know, and then do all this kind, because the whole program gets upset, right? Anyway, so that calls for us to come out of the current statutory body. I'm not saying what it is, and then get on onto a major platform. We are all healthcare professionals. We are just not only rehab. Rehab is a part of our work. Okay, now most of us are working in the hospitals. We are in the clinical setups. We are seeing patients, right? We have an array of people right from rehab to everything, head and neck cancer, swallowing, dysphagia, everything is there. So I see no reason as to why we are in the current council, but I think we should come out of it. I'm talking because I'm an advisory member of the National Council for Allied Health Sciences, which was mooted in Manipal in 2012. It's taken shape. There are 10 categories under that, which include the physios, the occupational therapist, the medical lab technologists, the optometrist, the medical imaging, then respiratory therapist, health information. So all of them are there. We're all in the hospital setup. Okay, they are in the hospital setup. They're all clinically based. So I think, it's high time that we also join the bandwagon. So from today onwards, my slogan is going to be how we come out and then, get into the right association. Okay, so I'll do my bit from that point of view. Okay, and I think, we have to have the support of all of you and also ISHA. So I hope that maybe, by the time that we have the next conference in Vijayawada, that is National Conference of ISHA. Sorry, in Vizag, Visakhapatnam, I think, that will fructify. And let's pray to the Edugundavada that, this will happen. Okay, so wishing you all the best and, bond with everybody, right? Think that we are all a family and we should always, strive for excellence, because our recognition, visibility comes from what we do to our clients, our patients. So sincerity, dedication, commitment, absolutely no substitution for that. So whatever we do, that should be our goal, and may our tribe increase. Jai Andhra. Thank you.
Thank you very much, sir. Now I would like to request Mr. P. Umar Khan to give his speech.
Good afternoon, everyone. So seriously, from the morning, we were discussing, we were, attending to scientific papers, and there were very good papers, 3 papers presented by 3 different people who have lot of experience in the field. I really appreciate those people. One, Kolkata, Chatterjee. So Chatterjee ji, so I appreciate your paper and your way of inciting and way of innovating the things and searching for the better outcome. So we are here. Helen Keller is here to print out your complete presentation as a book, and I'm promising you on this stage that Helen Keller will take up, if accept NIHH also, we will collaborate and we will print out the book, which could be helpful for the people. Then second thing, we have all come here all the way from more than 400, 500,000 kilometers traveling to interact, learn from the senior people. But I don't understand why this interruption was happened suddenly. In my 40 years of service, of course, 25 years of relationship with RCI, this type of hurdles were not seen. This was the first time I am seeing these hurdles and disturbing the smooth going on program. So I felt very bad for that. I want to write a letter to RCA chairman as well as the minister also. So this is insulting the professionals, and they cannot question the integrity of all the professionals. We are all here to learn and share our ideas. We have not come just for the sake of RCA giving credits. I hope that most of people will accept for that. because before giving this RCA credits, so our ISHA is to conduct so many programs, and National Teachers Union also conduct so many programs, but we have never come across this type of things. So I hope that this should be put police stop somewhere. Otherwise, as our Dr. Rajshekar Sir Guruji is telling, that we should, if they are not convincing, we have to quit and then join with the medical council. So that is what I feel. So it was debate for the long time, that we could join with the medical counseling, so that the professional quality would be enhancing, and we have so much of area to play a role as a speech pathologist as well as audiologist. So now the Sri Vidya has given a very good presentation. I have seen her way back in 1997 as a student, when she came as a BASLP student, how she was and how now she is. So it was a lot of difference. So just that shows that how much passionate she is in the profession. So I request all my students, those who are here, and the students from other colleges, be passionate to your profession. Be committed to the profession. So we are here to serve the people. We are all here to work for the mankind. So that is the reason we have come, not for just the sake of money making. We have not come for this profession. There are so many professions. We could have gone for that. But having the touch, heart touching, that only shows us that yes, we have to help the needy people. There are so many needy people in the, see, doctor was explaining her feelings. There are so many doctors also, they do not know what is autism, how the autism child can be rehabilitated and provide proper rehabilitation. And similarly, and many people do not know that concept in between speech and hearing, how connection is there. People says he's deaf only. No, he's not dumb. The people says he's not dumb, he's deaf only. So in even Telangana, some of the government officers, they started not giving the scholarship, and say once they write deaf and dumb, then only they give. Only if you write deaf, they are not giving. So that type of awareness also is required for the people to understand what is the the problem and its wavelength of the problem. So now, in fact, I started my journey with AYJ NIHH 40 years ago. So this 27th June. So Helen Keller is celebrating 40th year. So in this 40th year, sir, I started this small school when I was 26 years old. So as I was concerned to my district people. For my district people, hearing impaired children, I wanted to provide a school, small school. I started with small school. Now I proudly say that my students have been, crossed the borders of India, and they are working in different places. And this is only out of my commitment only this is happening. And even I resigned my government job also. So because I wanted to do something, I wanted to contribute something in this field. So that type of zeal one should have. I hope my students would be so understanding that you should be, commit for your profession and do wonders. So then only this profession will be come out, and we all together can help the people, those who are needed. And finally, I wanted to say that my Sirisha is also my student, and similarly in Andhra Pradesh there are nearly about 25 to 30 audiologists and speech pathologists are there working in Andhra Pradesh. Those students are telling me, sir, why don't you start a school, college here? So not only college, as sir was telling, I am planning for the rehabilitation sciences university. So here and maybe and Vijayawada or Guntur, because it's my native place. Like, so I born and brought up in Andhra Pradesh. So then now my complete service has been given to Telangana people. Now Telangana people says you are Andhra Pradesh fellow. Why should we help? So like that, those people are thinking. So then, why should I start the university there? I should start the university in my native place, whether here or in Kadapa. So that is what I thought. So in that rehabilitation science university would be there. Definitely that will be taking shape. I already spoken to education minister. So probably next year it will be going to take place, and that is what I wanted to convey to all the people. And in fact, the Guntur, earlier Guntur was having BSc program. Kadapa was having a BSc program. BSc ASLP was there. But due to some reasons, the main reasons was there was no students, number of students were very less. And therefore, they could shut down the college. If the college is viable, they could have not done that. So maybe 15, 20 years ago, that situation was there. Now the situation is different. The program, this university is affiliated with medical university. Definitely this could be possible. I hope that with the God grace, so I could come up to this level. I hope that that also in my remaining days, I wanted to make this institution as a university. That is what I am planning, not now. It's a 20, 30, 25 years dream. That is the reason I resigned my government job. I hope the people from here, so definitely they will help me to make my dreams come true. So I hope that so you people will be supporting me. So in the future, definitely we will work together. Thank you very much.
Thank you for your meaningful address and for your commitment to public service, sir. Now I would like to invite Dr. Aparna Ravichandran, whose contributions in clinical education and research are widely recognized, to address the gathering.
So good afternoon, the esteemed dignitaries on the dais and all the participants. I thank you all for coming here and participating in this CRE program. It gives me an immense pleasure to welcome you all to this city. You know that at my institute we are very, very, very strict on how you should attend your classes and all that. All of you, I think, have heard from me many number of times that you have to be there. I need you all in the class, in the seminar halls, in attending things. So I'm so happy that I'm seeing all of you inside the hall, attending, learning, gaining that knowledge. And I'm also seeing lots of you are writing notes. That really encouraged me. I was going back and forth, talking to people, seeing, and most of you have been making notes. Yes, I really appreciate all of you for taking this forward, for making this program a huge success. And I thank all the dignitaries to take out time, come here, participate with us, be with us, and help us, support us to make this event happen. I wouldn't like to take much time because we are all hungry, want to go for lunch. So, so let's break here. And I thank everyone. Rajshekar sir, it is a great pleasure having you with us. Sir is the sea of knowledge. So wherever, whatever you ask, sir, he will tell you. So I am happy that all of you are getting this opportunity to meet sir on a regular basis in Andhra Pradesh. So I hope sir will always be with us and help us, support us in doing whatever endeavors that Khan sir is planning, a new university. Sir is telling that a college. So let's see where all of us speech and hearing people to go together, and our body will grow in numbers. Our students will grow in numbers and we learn a lot, and our profession gets recognized all over India as healthcare professionals. We are no more rehabilitation professionals. We are healthcare professionals, and let us be that. Let us put that mark everywhere that we are on par with any other professional. We are not teachers. We are not specialists. We are professionals. Let's make that. So I thank you all again, once again, and give the mic back.
Thank you, ma'am. While the Lifetime Achievement Award arrangements are going on, I would like to request Mrs. Sirisha ma'am to take over.
Good afternoon, everyone. Good afternoon, all the dignitaries on the stage. Thank you for coming to the APASLPA CON Guntur. I am very excited to see you all, and I hope you had a very good stay. Actually, today there was a little confusion because of the RCI program. But next program will be going smoothly. I request all the sorry. Thank you for giving me this opportunity. Thank you, everyone.
Thank you, ma'am. As we have come to the end of the inauguration, now I would like to request all the guests to move on. So now we'll be going forward by announcing the Lifetime Achievement Award. Please, Tima.
Now it's time to announce the Life Achievement Award of APSLP 2025. The person is Mr. M.A. Srikanth sir. Please give him a big clap. And I will give mic to the Vanilla to brief about this. Sir. I request Falguni madam also be on the stage. Falguni madam, please come. Gopi. Lakshmi madam, please be on the dais. Please come.
Mr. M.A. Srikanth is a highly respected audiologist with over 4 decades of dedication service in the field of speech and hearing. A graduate of the prestigious All India Institute of Speech and Hearing, MISO, has begun his career in 1982 and has since become a pioneering force in audiological services, particularly across coastal Andhra Pradesh. Mr. Srikanth holds specialized training in cochlear implant audiology from Melbourne, Australia, and is recognized as the first qualified audiologist in Visakhapatnam. He has held several key roles throughout his career, including principal of Omkar and Lions School for the Deaf, and retired as an audiologist from the Hearing Aid Center AP, Differently Able and Senior Citizens Assistance Corporation, while also serving on deputation to both the Government ENT Hospital Visakhapatnam and the Government General Hospital Kakinada. An active contributor to the professional community, he is a life member of both the Indian Speech and Hearing Association and the Cochlear Implant Group of India, and is a registered professional with the Rehabilitation Council of India. He has presented papers, chaired sessions, and delivered guest lectures at numerous institutions and professional platforms, including Andhra University, Andhra Medical College, and several schools for the deaf and blind. Mr. Srikanth is the co-author of Basic Requirements for Setting Up a Speech and Hearing Center, a reference publication from ISHA, Mysore. As a resource professional, he has supported over 1200 government organized disability camps for hearing assessment and hearing aid distribution. His outstanding contributions have earned him several honors, including Dr. Vyagreshwarudu Memorial Oration in 2006, Lifetime Achievement Award from APASLPA, Dr. Oza Memorial Oration in 2023 by ISHA. He has served in leadership roles such as founder, vice president of the Andhra Pradesh Audiologists and Speech Language Pathologists Association, and as a nominated member of the ISHA Executive Committee. Currently, Mr. Srikanth is the proprietor and chief audiologist at Kishan Digital Hearing Aid Clinic, Visakhapatnam, and serves as a consultant audiologist for 3 major corporate hospitals in the city. He has also mentored more than 12 professionals in the specialized area of cochlear implant service. A revered figure in the field, Mr. Srikanth continues to be an invited speaker at leading national conferences and a mentor to the next generation of audiology professionals.
ఆడియాలజిస్ట్ శ్రీకాంత్ గారికి జీవిత సౌపల్య పురస్కారము. నిత్య కృషివలుడు, సహృదయులు, ఆడియాలజీ వైద్య రంగ సేవకులు డాక్టర్ శ్రీకాంత్ గారు ఆంధ్రప్రదేశ్ ఆడియాలజిస్ట్ మరియు స్పీచ్ లాంగ్వేజ్ పెథాలజిస్ట్ అసోసియేషన్ వారిచే మరియు డాక్టర్ ఈసి వినయ్ కుమార్ గారి యొక్క ప్రోద్బలంతో ఈ యొక్క జీవిత సౌపల్య పురస్కారాన్ని అందుకుంటున్న శుభ సందర్భంగా అభినందన చెందన మందారమాల తళుకు బెళుకు నక్షత్రాల మధ్య బంగారు కాంతులీనే చుక్కల్లో చందమామలోని సోయగాల్ని సొంతం చేసుకుని గగనతలం నుండి భూమాత ఒదిగిన ఆడియాలజీ ద్రవతార డాక్టర్ మాండ్యం అజీ శ్రీకాంత్ గారు అందాల హరివిల్లుతో దేదీప్యమానంగా వెలిగిపోతూ ఉషతో విరసిల్లే కర్ణాటక రాష్ట్రం మాండ్యం అజీ నారాయణ శ్రీరంగు పుణ్య దంపతులు ఇంట సరస్వతి మాత వరాల పుత్రునిగా జన్మించిన వైద్యరంగ ఆణిముత్యం డాక్టర్ శ్రీకాంత్ గారు. ఈ సరస్వతి మాత వరాల పుత్రుడు మైసూరులోని ఆల్ ఇండియా స్పీచ్ అండ్ హియరింగ్ నుండి డిగ్రీ విజయవంతంగా పూర్తి చేశారు. అతి చిన్న వయసులోనే 1982 నుండి కోస్తా ప్రజలకు సేవలు చేయాలన్న దృఢ సంకల్పంతో వైద్య సేవలు ప్రారంభించారు. ఈ చదువుల తల్లి ముద్దుబిడ్డ తనలోని నాలెడ్జ్కి మరింత పదును పెడుతూ ఆస్ట్రేలియాలోని మెల్బోర్న్లో కాక్లియర్ ఇంప్లాంట్ ఆడియాలజీ ప్రత్యక్ష శిక్షణ పొందిన గొప్ప మేధావి. ఈ వైద్య రత్నకారుడు ఏపీకి చెందిన డిఫరెంట్లీ ఏబుల్డ్ మరియు సీనియర్ సిటిజన్స్ అసిస్టెంట్ కార్పొరేషన్లో హియరింగ్ ఎయిడ్ సెంటర్లో ఆడియాలజిస్ట్గా అద్భుతమైన సేవలు అందించారు. ఇంకా ప్రభుత్వ ఈఎన్టీ హాస్పిటల్ విశాఖపట్నం జీజీహెచ్ కాకినాడలో హియరింగ్ ఎయిడ్ సెంటర్లో ఆడియాలజిస్ట్గా అత్యుత్తమైన సేవలు అందించారు. ఇంకా ప్రభుత్వ ఈఎన్టీ హాస్పిటల్ విశాఖపట్నము జీజీహెచ్ కాకినాడలో డిప్యూటేషన్లో కూడా సీనియర్గా సేవలు అందించారు. డాక్టర్ శ్రీకాంత్ గారు ప్రతిభకు గుర్తింపుగా ఓంకార్ అండ్ లయన్స్ స్కూల్ పందిడెప్కు ప్రిన్సిపల్గా అద్భుతమైన సేవలు అందించారు. విశాఖపట్నం బ్లైండ్ ఆఫ్ డెఫ్ సొసైటీలో కూడా విధులు నిర్వహించారు. ఆడియాలజీ విభాగానికి సంబంధించి దేశీయ ప్రాంతీయ స్థాయి పరిశోధన పత్రాలు అనేకం సమర్పించారు. వీరు ఉపన్యాసాలు ఇవ్వడంలో కూడా అందవేసిన చేయి. విజయనగరంలో డిఫెంట్ బ్లైండ్ సొసైటీ సామాజిక శాస్త్రీయ విభాగం, ఆంధ్ర విశ్వవిద్యాలయం, ఆంధ్ర మెడికల్ కాలేజీలో అద్భుతమైన అతిథి ప్రసంగాలు చేసి నెంబర్ 1 ప్రసంగకర్తగా నిలిచారు. ఆడియాలజీకి సంబంధించిన కొన్ని పుస్తకాలను సహరచయితగా కూడా సేవలు అందించారు. డాక్టర్ శ్రీకాంత్ గారి మేధస్సు అద్భుతం, అమోఘం. అన్నచందన ఇండియన్ స్పీచ్ అండ్ హియరింగ్ అసోసియేషన్లో చైర్మన్గా ఏపీ ప్రభుత్వ వికలాంగుల సంక్షేమ శాఖలోని 1200 పైగా వైద్య శిబిరాలకు రిసోర్స్ పర్సన్గా ఎంతో గొప్పగా సేవలు అందించారు. డాక్టర్ శ్రీకాంత్ గారు విశాఖపట్నంలో మొట్టమొదటి క్వాలిఫైడ్ ఆడియాలజిస్ట్గా అరుదైన గౌరవాన్ని సొంతం చేసుకున్నారు. ఇంకా ఎన్నో స్పీచ్ అండ్ హియరింగ్ అసోసియేషన్స్కి లైఫ్ మెంబర్గా తన సేవలు అందించారు. కాక్లియర్ ఇంప్లాంట్ సేవల్లో భాగంగా లెక్కకు మిన్నగా వృత్తి నిపుణులకు మార్గదర్శులుగా, గురువుగా, ఇంకా చెప్పాలంటే రోల్ మోడల్గా కూడా ఉండి గొప్ప ఖ్యాతి గడించారు. డాక్టర్ శ్రీకాంత్ గారు పురస్కారాలు పంటని కూడా అద్భుతంగా పండించారు. 2006లో డాక్టర్ విఘ్నేశ్వరుడు మెమోరియల్ ఓరియేషన్ పురస్కారం, ఏపీ ఆడియాలజిస్ట్ అండ్ స్పీచ్ లాంగ్వేజ్ పెథాలజిస్ట్ సంఘం వారిచే లైఫ్ టైం అచీవ్మెంట్ పురస్కారం, 2023లో ఇషా వారు అందించే ప్రతిష్టాత్మక డాక్టర్ ఓజా మెమోరియల్ ఓరియేషన్ పురస్కారం అందుకుని ఈ పురస్కారాలనే వన్ని తెచ్చారు. జనని జన్మభూమిచ్చ స్వర్గాదపి గరీయసే అనే స్ఫూర్తితో ఆడియాలజీ వైద్య రంగంలో అద్భుతమైన సేవలు అందించి మాతృభూమి రుణం తీర్చుకున్న ఈ వైద్య రంగ ఆణిముత్యం డాక్టర్ శ్రీకాంత్ గారు ఏపీ ఆడియాలజిస్ట్ అండ్ స్పీచ్ లాంగ్వేజ్ పెథాలజీ అసోసియేషన్ వారిచే 2020 సంవత్సరంగా అందిస్తున్న ప్రతిష్టాత్మకమైన జీవిత సౌపాల్య పురస్కారాన్ని అందుకుంటున్న శుభ సందర్భంగా డాక్టర్ శ్రీకాంత్ గారికి మా శుభాభివందనలు, జేజేలు, వందనాలు. మీ ఆడియాలజీ
Ways to bring him inside. I got 1 for the ladies, 2 for the man, 3 for the ravers, the right there skanking. I walk to the rhythm, I properly kill him like watch the delivery. The flow ain't up for them. Try not to overdose. It's time to let go. The people they know they're losing control. And that's what I want about. Run your mouth and watch how we knock them out. It's the knees of Jesus, brother, get your heat up. We just bust the speakers up.
Hearty congratulations to sir from the team of APASLPA. Now, yes, we all are ready to go out, right? Yes, we can jump out. So sorry not to jump out. Yes, stay on. We are expecting a RCI call again. So
जाऊंगा, ठीक है? उन बच्चों को बताना प्रेजेंट है या नहीं प्रेजेंट है तो उनको बुलाइए और एब्सेंट है तो उनको बताइए, ठीक है मैम?
ठीक है जी, समझ आ गया। ठीक है, ठीक है।
बच्चों का नाम लेते रहूंगा।
हाँ, एक सेकंड रुक जाइए बस। हाँ जी, हाँ आप बता दो, नाम बताओ।
सारे बच्चे आ गए?
लगभग सब है।
ठीक है।
लगभग है, अगर नहीं है तो हम बुला सकते हैं, पर टाइम लग जाएगा, पहले ही बोल रहा हूँ आपको।
आप स्टूडेंट है क्या यहाँ पे?
नहीं जी, मैं इधर ऑर्गेनाइज करवा रहा हूँ इनसे।
तो ये तो देख लीजिए आप किससे बात कर रहे हैं, कैसे बात कर रहे हैं।
अरे ठीक है जी, आप बताओ, मैं तो आपको। ठीक है जी, आप बताओ फिर।
मध्यम अजी श्रीकांत।
अजी श्रीकांत।
मध्यम अजी श्रीकांत।
मंडयम आजी श्रीकांत।
सीआरएल नंबर, जीमेल आईडी, फोन नंबर, तीनों चीज बताइए।
00083। फाल्गुनी श्री।
फोन नंबर।
फाल्गुनी श्रीकांत @gmail.com।
आपका फोन नंबर
9849112993 फोन नंबर।
ठीक है, चाहिए। पठान उमर खान।
क्या जी? खान सर।
पठान उमर खान।
Hello, sir. Good afternoon, sir. My RCA number is
नाम क्या आपका?
Umar Khan. Pathan Umar Khan.
ऑर्गेनाइजर आपका नाम क्या है? आपका नाम क्या है?
गोपी वेंकटेश।
ये ऑर्गेनाइजर जी का नाम क्या है जो अभी फेस्ट लगाया था जिन्होंने?
स्नेहिल
आपके लिस्ट में सबसे ऊपर नाम किसका है? लिस्ट में सबसे ऊपर नाम किसका है?
एक सेकंड रुक जाइए।
आर सिरिशा। आर सिरिशा।
इनका सीआरएल नंबर क्या होगा मैम?
Sir, my RCA number is A07693.
मैम मैंने बुलाने के लिए नहीं बोला था, मैंने सोचा था मैम।
A07093.
वॉशरूम में हो गए।
सर
एक्सक्यूज मी सर, आपको आवाज आ रहा है?
म्यूट में रहे।
वाल म्यूट लो ना।
But everybody will listen.
switch off. Mic is not for us.
And that too, no. Even if someone listens also, they are coming, sir. Immediately.
एक्सक्यूज मी सर, हेलो।
Full style, I'm out.
resource person. देखिए, last 3 hours, the scientific program has been stopped now. I'm telling you now, then how will you, how will they conduct the program? And I'm talking to you, I'm very senior RCA inspector. Have you RCA? See, but whatever it is, no, whatever it is, आपने तो ऐसे ही किया वो जो SRM यूनिवर्सिटी में भी आप ऐसे नहीं किया, ऐसे किया 3.5 hours, you held the program, scientific program. Okay, no statutory body can do this.
मैंने वही बोला था आपसे पहले आप
Okay, no. We will talk to the member secretary as well as to the chairperson also. Okay, you please carry on. But I just wanted to tell you that our scientific program is getting affected. So 3 घंटे हो गए. Okay, we are not able to proceed. Now how will we run the program with so many delegates?
Sir, you
आप बोलिए ना. No. We will send one letter mail to the PMO's office. Okay, you please carry on. You please carry on. Okay.
जी सर, हेलो सर.
हाँ जी सर.
Sorry for the delay. Yeah, let us go forward.
स्पेशल कहाँ पे थे हम?
एक सेकंड सर.
हॉस्पिटल स्पेशल कहाँ पे थे?
A54733.
अच्छी बात करिए मैम.
A41880.
Next.
A57264.
57.
A57264.
Wait a second. Next.
A52526. Absent है. Sir, absent है वो.
Wait a second.
A23062.
ये 5 to 5 के बजाय था आपका नाम?
वो absent है.
मैम एक मिनट देखिए तो.
A23062.
मैम आपने ये 5 to 5 बताया तो देखने दीजिए ना.
ये A5256 एब्सेंट है सर. ऑलरेडी हमने एब्सेंट मार्क किया है.
He is a true pioneer in the field. He was the first ENT surgeon in India to perform the combined thyroplasty type 1 and retinoid adduction surgery for unilateral local fold paralysis in 1996 and published his work. He also introduced transnasal endoscopic office based laryngeal surgeries in India in 2005 and has performed over 10,000 such procedures to date. His contributions include organizing the first All India phonosurgery workshop in 1999 and developing new techniques like office-based cordotomy for bilateral local fold paralysis, which he has presented globally. With numerous national and international publications and invitations to speak at prestigious conferences, he continues to inspire generations of ENT surgeons and voice specialists. Please join me in welcoming Professor Dr. V. Fanindra Kumar to deliver his talk on team approach by SLP and laryngologists for successful outcomes in voice and swallowing disorders. Please give a round of applause. Now I It's my pleasure to invite the Mr. Kiran and Mrs. Bhuneshwari Vinod to chair this session.
Good evening, everybody. Thank you, Kirti Prasanna, for her nice introduction. And first of all, let me thank the organizers of Andhra Pradesh Audiologists Speech Language Pathologists Association for this unique meeting and give me an opportunity which I feel as a prestigious issue. Now, the topic is the team approach of laryngologist and speech language pathologist for successful outcomes in voice and swallowing disorders. You know, you must remember that as a ENT surgeon or a laryngologist or otologist or whoever it may be, and speech language pathologist, they're like milk and water. You can separate them. You cannot separate them. But if you want to dilute, maybe put water, or if you don't want to put more milk. That's all. So you cannot separate them. So it will work. It will go automatically together. So it is a part and parcel of your work. So it should be always a teamwork, whether you do otology, laryngology, anything. Now we are discussed today. My topic is on the laryngology and which is concerned with voice and swallowing disorders, because I'm primarily my practice is on laryngology in ENT. You know, the multidisciplinary clinics with a laryngologist and speech language pathologist have been widely regarded as the gold standard of practice for evaluation of voice and swallowing disorders. This has been good practice in Western countries, but unfortunately it is still in infancy in India. Because the reason for that are there are not many laryngologists in India, number one, and similarly there are not many voice pathologists. Either a laryngologist is one who trained in a ENT surgeon who trained in laryngology. Similarly, a voice pathologist is a speech language pathologist who has a special training in voice and swallowing disorders. So there is a lot of depth or the deficit about this specialty in the country. Coming to the voice disorders, every one of you know it is difficult to demarcate as organic and functional in the diagnosis and management of voice disorders because one may predispose the other. That's why I am telling you, you cannot demarcate. This is functional, this is organic, because one may predispose. We don't know which is first, which is next. Sometimes one may, this is a cause for the other. The laryngologists are concerned mostly with the restoration of structure of the vocal folds or the vocal tract, you call it, whereas SLPs are responsible for restoration of its function. So there is no point of reconstruction structure without function. So which is more important? The function. So the SLPs. So the lot of demand, a lot of importance for SLPs, you must know that. So just like you do audio verbal training in cochlear implants, here also is also equally important. You must know that. So speech language pathologists who have specialized training in voice disorders are usually called as voice therapists or SLPV in Britain. They call them SLPV in Britain. Now, what is the actual role of this speech language pathologist? SLP is the key person in the evaluation of the voice disorder patients. They have them in the clinics, in the voice clinics, they have a special questionnaire form will be provided for both professional and non-professional voice users. This generally involves evaluating these various characteristics like respiration, phonation, resonance, vocal range and flexibility. Apart from this, it is also the psychological aspects of the patient. Once the patient enters your consulting room, you must be able to read him properly, because the most important thing, what are these maneuvers, how he is doing. So this is very important. So a comprehensive assessment to identify the voice disorders includes most important case history. So nothing like case history in the diagnosis of any disease. So here also case history is the most important. So you must have good patient to have patients. You must have to obtain a proper case history. Example: the onset of and symptoms, medical status, history of previous voice treatments, daily habits related to voice hygiene. Even the occupational patient is very important, because most of the people, professional voice users like singers, teachers, lawyers, lecturers, advocates, there's so many professional voice users you come across day to day with voice problems. So the professional voice users are also again classified into 4 varieties: allied professional voice users, 1, 2, 3 like that. So the professional voice users are the of all these things, singers comes the utmost important professional voice users. Coming to the role of SLP in pre and post-operative therapy. The treatment plan in voice disorder patient always starts with SLP. Please remember. So when the patient comes for a voice disorder patient enters your chambers or office or what called consulting room, a SLP is the first person to take up good counseling, history, and then decide the functional status of the patient. And always it ends up with SLP again with voice therapy. See, it starts with SLP and ends with SLP only. So this you must know how much importance is there for the SLP, how much responsibility on SLPs in the management. Based on the evaluation and diagnosis by otolaryngologists or laryngologists, SLP will develop a personalized treatment which includes breathing techniques to support the efficient vocal production, exercises to improve the vocal control, strength, strategies, etc., occupational demands that may affect the voice. There are various ways to optimize the voice in day-to-day communication, both in pre and post-operative periods. So, when the patient is planned for surgery, this starts with SLP, pre-operative voice assessment and therapy, surgery followed by post-operative voice therapy. This is mandatory for all cases. Now let us take some examples. I am calling as what that is. You know that most of you know what is hypokinetic dysphonia. Similarly, you got hyperkinetic dysphonias. So I am talking first about this hypokinetic dysphonia. The most common example is the vocal cord paralysis, unilateral vocal cord paralysis. That is called as paralytic dysphonia. That is due to unilateral vocal fold paralysis. So you can find here a small video clip here. You can see here. See, only one vocal cord is moving, and the problem in vocal cord unilateral vocal paralysis is there will be a gap between two vocal cords. The air waste will be there. So because the air waste, the patient will have something like a breathy voice, hoarse voice. So if the gap is more in the posterior aspect of the larynx, the breathy voice much more. So you can find here patient can have breathy voice, hoarse voice. All of you know about Graph's rating scale. I think every one of you know about Graph's scale. So we based on that we do perceptual voice analysis. Now here you find this. So that gap is left, glottic gap. So what we do in surgery is we do what is called thyroplasty type 1, or this is also called as medialization laryngoplasty. That is simply what do we do here. You can see this is the cord which is paralyzed. See, this is the left cord. Okay, this is the cord paralyzed. So this cord is moving. So this normal cord trying to come close to the paralyzed cord and try to close the gap by compensation. So this what you do in your assessment also when you do pre-operative therapy. I think you try all these cases effort exercise. If I am right, effort exercise are given for the patients with a paralytic dysphonia. So when you do effort exercise, what to give more effort is given on the normal cord so that it comes more close to midline and gap is closed. So anyhow, in paralytic dysphonia, the first line of treatment is voice therapy. Voice therapy. And when the voice therapy is not successful, then you go to the other methods like injection laryngoplasty or thyroplasty. The procedures. Now, so this is the case where you find here the glottic gap is there. So what happened when you operate? See what we did. So what we did is we pushed the paralyzed cord towards midline by the implant, putting in the neck, in the laryngeal skeleton. So the glottic gap is closed. Now you can find that patient hears the voice. See, gap is closed. So the breathy voice has gone. So that principle of thyroplasty. So this is principle of thyroplasty. So these thyroplasty surgeries are done on local anesthesia. So all the patients who undergo thyroplasty, they will be speaking on the table. You can see here. Number చెప్పండి. While you pitch. See, this patient is 88 years. This was operated recently by me, and this is the oldest man operated in the world. So we did it. This is the oldest man operated in the world. So we did it in India. In the month of May. This is now it records thyroplasty. Oldest man who operated thyroplasty in the world is the 88 years old man. So you can see here this operated in local anesthesia. So this operation is done by monitoring the voice on the table. So patient will talk, you can monitor the voice also. At this time, usually the speech language pathologists or voice therapists to stand by the side of the surgeon and assess the perceptual condition of the voice. So they usually they should stand with the surgeon and assess this. I will show you why, because and see, actually I am not going to details of surgery here. So this is what the surgery we are doing here under local anesthesia. Oh, this is the arytenoid we expose here, and then we rotate the arytenoid and then fix the vocal cord. This is all the surgical aspect. And here also you can find, once you fix the voice, the patient starts speaking. See what you find here, once you are operating. The result we should get on the table, operating table is not the final. Because that is only at a near normal voice we get. But we get the better voice, normal voice after therapy, not immediately on the operating table. Right? I will show that. So the role of laryngologist is tympanotheroplasty with erectile reduction for correction of plastic dysphonia. Whereas role of SLP in these cases is before surgery, effort exercises. This is the first line of treatment. And after surgery, post-operatively, what is called relaxation focus changing techniques are we apply. That is usually done. Now I'll tell you, I'd like to show you here. This example, what I told, this is what the patient just now has seen operating on the table. See, for example, you see this old man, he almost is aphonic. That means no voice. See, just see.
January, February, March, April, June, July, August, September, October, November, December. I 25.
Okay, so you have seen his voice before, surgery, theraplasty. So 2 weeks after surgery, just watch it, I just hear his voice. See, what do you find? His voice better than before, but not that satisfactory. Is it not? You agree with me? His voice good, but it is not that good as you expect. Just see, just watch. You know the reason? The reason is he has a associated MTD. That is muscle tension dysphonia. Apart from paradysphonia, he tried his compensatory maneuvers before the treatment. Most of the people that go for compensation, so they go into muscle tension dysphonia, MTD we call. So because of that, his voice is still harsh. So now we see. Now we can see here. This is after voice therapy. 2 months or 3 weeks after voice therapy. So before surgery, his voice was like this. So that was his voice before surgery. And this is after surgery. Surgery plus voice this is what I'm doing. This is called team approach. It's a team approach. It's a team, not one person, surgeon and the therapist. Coming together only where outcomes are, we can get the best outcomes. This is an example of hypocognitive dysphonias. Now, the other problems are hypercognitive dysphonias, which you find most commonly the hoarse voice, husky, rough voice. These are the either maybe due to vocal fold masses or in case of voice. You can talk while operating, you can monitor the patient voice. At the same time, the SLPs also can assess the perceptual status of the voice also can be done. So this is the one. I just can find that by removing that mass and for biopsy. Okay. So this is about briefly about surgery. I'm not going to details of the surgery here. And okay. After the treatment, again you do, of course, after 2 weeks you do stroboscopy, you do it. So what happens? The vocal cord appears normal, but still the voice is not good. Well, voice is not good. You remove the mouth totally, but still the voice is not good. So here comes. See, what you are seeing here, I would like to show why I am doing this video. Please watch carefully. Apart from mass in the stroboscopy, you find anterior to posterior contraction of the anterior posterior. So that is contraction of the larynx. That is again due to muscle tension dysphonia. This is anterior posterior compression. Here the anterior posterior compression you can find here. So this is the epiglottis is coming and touching the arytenoids. So that means patient has severe muscle tension. So that voice also becomes very hoarse with this one. Apart from so after surgery and then patient this is before surgery. That is voice was before surgery. Now let us see how his voice after operation. After surgery, we are not happy because we don't much change before surgery and after surgery. Why? Because the mass were removed, the hoarseness will come down, but still he is having a harsh voice. Yeah. So I pause. So what is we are going to do is we can go the next one. The next session will go. So now you can hear the voice of voice therapy. How is the voice was this? Ultimate is therapy. We can help him. Okay? So clearly you can find, I would like to show the everybody knows this is spasmodic dysphonia. And we do here Botox injection. And we do Botox trans endoscopy, not to the neck. There don't need no laryngeal EMG. We do directly to the muzzle. This is the Botox injection. This is thyroid muzzle. We inject directly to the muzzle, and you can find the patient's voice.
Excuse me, sir.
So this is the typical case of spasmodic dysphonia. After injection, then after 1 month. So unfortunately, Botox works only 4 to 5 months. So it's why I'm telling this patient also having associated muscle dysphonia, which is also corrected by voice therapy. So other aspects of are the pre and post operative voice therapy also essential for pitch modifications like people androphonias, singing voice therapy for singing coaches, and any SLPs who knows the singing techniques. Any singers here? Singers. So if you are a singer, you have another advantage as a singing for singing voice. You can do much better job than the simple pathologist. And you have got other methods, behavioral compression, cough compression therapy, respiratory retraining therapy for paradoxical vocal fold motion disorders. And gender, similarly, we have gender identifying evidence when transgenders also voice therapy is a lot of importance. And now coming to swallowing disorders, we got transnasal esophageoscopy and video fluoroscopy are also very important. And actually, it is practiced in many countries like Europe and America by SLPs only. And swallowing disorders, SLPs have got a major role than the ENT surgeons. So they must be able to do the not only therapy but also these procedures also. Like this is the transnasal esophageoscopy you can find here. How the esophagus is done, and this is the video fluoroscope swallowing, and this is the normal, and this is the abnormal. You can find here. So these are all the things which are also very important for a team approach. So swallowing therapy, you know very well, they are very important. Various maneuvers like shaken maneuver and expiratory muscle strength training, chick turn technique. I did not tell you, you are aware of these things. And all the SLPs must be well trained with all these techniques because swallowing disorders are becoming increasing lot of demand. So to conclude, the evidence is the benefits of multidisciplinary capable laryngologists in SLP to evaluate, treat and swallowing disorders include improved adherence and recommended behavioral therapies, improved overall outcomes and less revenue lost due to dropout and no show rates. Thank you for kind attention.
So thank you so much, sir, for your wonderful presentations and with a very good case presentations and pre and post progress in those patients. Wonderful work, sir. Thank you so much, sir, for being with us today. Thank you.
Thank you very much, sir. Your pioneering work and deep expertise in the field of voice surgery have not only advanced clinical practice in India, but have also felt a lasting impact on the global medical community. We thank you very much for your presence here, sir. If anyone have any questions regarding the topic, you can ask sir directly. Now, I would like to request Dr. B.S. Premulata to join us to felicitate, sir.
I take this. So thank you so much, sir, including SLP as a voice therapist in your team and giving a due credits what is required. So more and more surgeons should come forward to include SLPs in their team to recognize and give due credits. Thank you so much, sir. And along with that, just I wanted to add one more thing. In hypokinetic paroxysmal voice problem, usually they do complain of aspiration for liquids. So along with the laryngeal adduction exercise, before sending them for Theraplasty 1, we give them the laryngeal adduction exercise, try to improve their voice quality. Along with that, reduce the aspiration for liquids. If it doesn't calm down, then only we refer them for a laryngologist for a Theraplasty 1. That's a trend usually we follow in Bangalore. We give them the 6 months training and wait for the recovery to happen. Doesn't happen, then only we recommend them.
Hello. Thank you, Dr. Premulata, for your wonderful comments. And I take it as a privilege to meet all of you at this hour and discuss about this aspect. In fact, I also encourage the associations to start a special training for SLPs and fellowship programs in the laryngology. That's called SLPV. Or SLPV, that is special program is essential. Yesterday you were talking, I encourage to have a fellowship program, to have it, because you have to learn a lot about this aspect. And there is a need also for this. That is very important.
in Bangalore, in Chandrasekhar Institute of Speech and Hearing, we do run a fellowship program for head and neck cancer following speech and swallowing rehabilitation following head and neck cancer. It's a 6 months program, and
No,
we'll
what
be
is
placing them
happening
in a different
in India?
setup
In
also.
India, problem is there are many voice pathologists. Number one, and there, what is phoniatricians? Phoniatricians means a laryngologist is a medical laryngologist, not surgeon, but who practices therapy.
Voice therapy.
So we have become phoniatricians because we have to operate, we have to do ourselves therapy. Because there are no people coming forward to learn the techniques. So every job we have to do.
I'm sure another next 10 years scenario will change, and more and more SRPs will come forward to become a SLPV, as you said, and become a diglotologist also. Because more and more SLP wants to work in a hospital setup, and as Dr. Rashekar said in the morning, instead of calling ourselves as a rehabilitation expert, we are a healthcare professionals, should be attached to the hospital setup so that we'll know how much we can contribute and what all the things we can contribute.
Yeah, okay.
Thank you, sir. Thank you very much. Can I have a round of applause to sir? Thank you, ma'am. Thank you very much to everyone. With that, we move on. Now we move on to the one of the most engaging and thought-provoking segments of today's event, the panel discussion. Sorry. On the topic, how can we help ourselves to mitigate the challenges faced in our profession? To guide and steer this important conversation, it is my pleasure to invite our moderator, Mr. M.S. Srikanth, a respected professional known for his insights, leadership, and active involvement in shaping our field.
మూడు మూడు చైర్ పెట్టండి
సార్ అటు 3 ఇటు 1 చైర్ పెట్టమని చెప్తాను సార్. మీరు ఇక్కడ కూర్చుంటారా?
Now I would like to invite panelists for the panel discussion. I would like to invite Dr. B. Rashekar to get onto the stage, sir. I would like to now invite Mr. Nitish Regri from Hyderabad. Now I would like to invite Mr. Sai Koti to be as a panelist. I would like to invite Mr. Sai Koti to be as a panelist.
ఉంది. First of all, I thank the panelists. Let us start the panel discussion. I know we are already delayed because of some obstructions, but still we will try to keep it short so that the other speakers don't get delayed. But we will go to the point because this is a major point now being discussed in many of the conferences. మన అన్ని కాన్ఫరెన్సెస్లో మన ప్రాబ్లము పే ప్యారిటీ, మమ్మల్ని ఎలా పిలుస్తున్నారు, మమ్మల్ని ఇలా పిలుస్తున్నారు, మాకు రికగ్నిషన్ లేదు, ఇదే ప్రాబ్లమ్స్ ఉన్నాయి. ఇది ఇంక్లూడ్ చేయండి అని చాలామంది రిక్వెస్ట్ చేశారు మన అసోసియేషన్లో. మన స్టేట్ వాళ్ళకి చాలామందికి ప్రజెంట్ పొజిషన్ తెలీదు. ఫ్యూచర్లో మనం ఎలా ప్రొసీడ్ అవ్వాలి, హౌ టు ప్రొసీడ్ ఇన్ ఫ్యూచర్, దట్ ఆల్సో దే డోంట్ నో. సో వీ ఆర్ ఫేసింగ్ సో మెనీ ఛాలెంజెస్ ఇన్ అవర్ ప్రొఫెషన్. Of course, from 30 to 150 we came, numbers increased, but still we have so many hurdles to cross. So one by one hurdle, how we can cross? We have to be united and we have to cross these hurdles just like the other professionals like physiotherapists did. So what is the road ahead? We wanted to discuss. So we called 3 people from 3 different kinds of setup. One who worked in a hospital setup with colleges and academics. One who is in a purely private practice, one who is in a corporate setup. So we wanted to know from each person their perspective how we can move ahead. Next slide. Full scale. So I don't think there is anybody in our field who has not faced a problem in their practice or profession, or I don't know. I don't think there is a blessed one. But I want to know from these people, have they had any problem with people unqualified, underqualified? Then if they have found, what all they try to do to overcome that problem. First let us ask Dr. Rajshekar. ఇంకొక మైక్ ఇవ్వండి. ఇంకో మైక్ ఎక్కడ ఉంది? You can pass on the mic, sir.
Hello. Yeah. Thanks, Srikanth, for this question. I think it's question of great relevance. But me, because see, I've been throughout in an academic institution. I've been in a college, I've been in a university. I've really not faced this problem of unqualified persons. But when I joined Manipal way back in 1976, because we didn't have qualified people, right? The Department of ENT had trained somebody, okay, who was doing the routine proton audiometry, okay, and he was also giving certain voice therapy and all that as directed by the ENT. 76, I accepted because there was not many people were there. But after I joined, with due respect to him, because he was quite a senior person by age also, I slowly told him that, that say, look, there are different ways of doing things, right? So doing it on prescription, doing with experience and knowledge is going to be a different thing. So ultimately, he also understood that. So he was with us, but then he took a back seat because we were the ones who started doing the assessment, diagnosing, discussing with the ENT or the neurologist or the pediatrician, and then planning up the intervention programs. So he was with us as an associate. He was not qualified, but phonics, what do we do all that? So I told him, he went and read up, we do all that. So I told him, he went and read up. And even when I told him about what's a silent cough method, he came out and said, yes, sir, it is Zimmerman's technique. That means he has taken interest to read that. But otherwise, I think now in the present context, I don't think that we should encourage, and I don't think that there could be many, but not in academic institutions. Maybe in the private, there could be some.
Yeah, there are many in private practice, sir. That's why it goes to the Nitish.
Thank you, sir. That was a wonderful question. Actually, my experience is completely different, where I have gone through different modes in different places in India, where I have seen clinicians of or service providers of a different sort. I would not want to call everyone clinician, but the intent that they had for the intent behind what they do is different. Few people had a clinical intent where they want to provide a clinical service. That is one. Whether it is clinical service that is to do with testing a patient, or clinical service that is to do with giving them a solution. And in our front, the solutions that we give are therapies, hearing aids, implants, or doing the mappings and stuff. These are the three primary areas is what I would say. But the challenge is where the intent is something else. When I say something else, transparently, it is to do with so-called behaving as if they are solving the person's problem. Most of the time there. And the reason behind this very action is because there is no strong body that could control this segment of it. So they tend to do whatever they want. And this weakness is in almost every state. And I would actually say that this is more towards the north, I say. Yeah, more than the south. So there are different organizations, ISHA being one core, but there are other state level organizations also which try to fight in a different way. But I think people are not on the same page. Again, on in the front where people are fighting for it, they too have their specific agendas, which also has a personal front to it, personal touch to it. That should not how it should be. So so the challenges, coming back to that challenges part, hearing aid dispensing, it has gone really south, or I mean all towards the negative side. Implants also have grown to some extent now, but earlier the decision making was on the other side. So at the end of the day, it is important to know where is the cutoff for a professional, for a qualified, I would say more than qualified, a learned professional. Okay. And now there are these streamlined methods of taking a qualification and then being called as a learned. Okay. Earlier, there was that passion that was driving them into that segment, what you said. So, so it is good way to get qualified learn it. There are workshops, there are so many activities, and it can also be streamlined. ISHA is conducting so many wonderful activities, SIG campaign that they were running. But I think things have to be streamlined. There is somewhere where we are weak, and we have to strengthen ourselves, is what I would say.
Yeah, now before I ask Sai to say, I must congratulate Sai and his organization HereZap. They have made a framework where only qualified people are appointed. There are so many other chains who appoint unqualified, underqualified people, but they have made a framework only. So many of our graduates are able to get jobs, satisfactory jobs which fits their qualification in their organization, but still they would have also faced some challenges. So I wanted to ask this to sir.
Thank you for recognizing us, sir. My experience, I would say it's not completely different, but since we focus mostly on hearing aid, I would not say dispensing. It is like providing a service with fitting of proper hearing aids with proper technology and when to use, what to use. We have devised certain protocols, like we can't just randomly pick one hearing aid from our whatever the stock we have and we just try to put it on the ears. Rather, we have described, I myself is into L&D, that is learning and development department. So I train regularly around 200 people who are qualified audiologists. So here the question sir is asking is, how are we going to tackle with the non-qualified audiologists? So if you observe, sir, since 2014, 2015, this when we started this organization or this particular group, this has been a continuous debate at various levels with varying tones. Every year we all gather, we discuss what to do, we leave, we practice our own practices, nothing raised, or once in a while someone questions, none of them speaks again. So today, how many of you feel that we are not as threatened as earlier? Can someone raise your hands? I would very strongly raise my hand that today I'm not at all threatened by any non-qualified so-called professional who calls themselves as doctor. None of you? Are you still worried about the non-qualified people practicing in your area?
Yeah, there are so many.
Is anyone worried is my question. If that is the case, then can someone tell me why are you worried about them?
Yeah. Why are you worried? Yeah.
If you are not worried, please raise your hand. If you are worried, please give me a valid reason. Why are you worried about them?
I'm closest to Sai Koti, so I would take this opportunity about my worry. My worry is that non-qualified would do a give a wrong type of analysis and give a wrong solution to that patient, and that particular individual would suffer. That is one worry for me, because it is my clientele. He is dealing in a wrong way and there is no action that can be taken on him or is not being taken on him. That is one. And secondly, there are so many accidentally successful individuals out there, and they kind of give solutions, patients are satisfied, or else give good so-called deals, and patients are okay with that, and therefore it's worrisome for quite a good chunk of people, is what I would say, who wants to start their practice, who wants to do good work in the market and all. But the spoilers primarily are those who don't play technical side of it, but who would play deal side of it. So that is where it worries most of the professionals.
Yeah.
With your permission, I just wanted to endorse both the youngsters. The concerns. I think I also share the concerns. The concerns are, number one, as you rightly said, a wrong diagnosis and wrong intervention, which means with these negative ramifications for the persons we serve. That's one thing. It could be your own uncle, your father, your mother, whoever it is. Okay, they go into such people's hands, right? They're given a raw deal, number one. Number two, it's also a blotch on our profession, because somebody does it who's unqualified, but the society thinks it's the audiologist who has done it. So what happens?
They even put audiologist name in their name.
So that means it's a black mark on our society. That means 10 people do good, one person does it. All the good work done by 10 people gets totally kind of eroded. That is the okay. Second thing, the two things. things. One is for the patient and one is for our profession. That's why it's, I think, of deep concern. And I think all of us, if we understand, realize, and if we are aware that somebody is unqualified, is doing it, I think we should take the initiative to report it to the concerned people, or at least let people know, right, that he is not qualified and he should be doing this.
Yeah. So, yeah, I just, without any bias to any of the panelists, I support both the views. We have to improve our skills. If we improve our skills, that's what Sai was mentioning. If we improve our skills, we need not have to worry about the unqualified person. So Sai was trying to train it, but that doesn't mean we allow unqualified person to practice. So his concern,
even the client
Nitish
has
concern
become
is also
more,
is
yes,
right. So that's why we don't want bad service delivery because of a person who is this thing. So we usually earlier we used to give them a chance to upgrade. Like there are so many diploma holders now who have now done their graduation. They have upgraded. Good enough. Now they are qualified. They can do better work. They have learned. So that is one solution I thought. Maybe other solutions also we can think of. Next I will go to this most important problem in our this thing. Yeah, Premlata wants to add something.
The panel discussion is going on only towards the audiology. What about the speech pathology?
ma'am. It's nothing different, ma'am. I think
No,
Lakshmi ma'am has
say
an
I
answer.
don't know, but in here, Bangalore scenario, there is no question of unqualified speech pathologist because whoever has got a clinic, they are overqualified. You can say that because they have a team approach and they have worked in an institutional setup and passed out from the institutional setup, recognized RCA recognized institutional setup. There is no question of unqualified SLP. That can happen only in audiology, but not in speech.
Ma'am, even
Madam,
today,
that is wrong. That is wrong. I disagree. I know some speech therapists in Bangalore who gives the speech therapy for stuttering without any qualification. Yeah, yeah. Many minimum. Yes. You say problem is we are talking about Andhra Pradesh. There are many here. We are not metropolitan cities is not a big problem. It's
ma'am,
yeah. Here,
especially end of
here
the day,
every cochlear implant child's mother is a speech therapist without qualification. Every deaf child's mother is a speech therapist without qualification, handling 10 or 12 children. So good, because she knows the problems of their child. So she may be very good. But what we are advising is let her get some qualification. That's what we are.
sir, I have a point here. If we are worried about non-qualified or underqualified people starting a setup and serving the community, why don't we see any of our own audiologists starting a setup? See, as we are discussing, like today, I can confidently say any audiology setup, the client has become more evolved. They are more cautious. They are more understanding now. Today, they themselves are retrieving from going to a non-qualified audiologist, because end of the day, even if they are lured with some sort of discount or some sort of offers, as my colleague was saying, end of the day, within 1 week or within 10 days or within 1 month, they come back, they question, this is not working out, and by the tone or by the answer given, they are bluntly, relently giving back the hearing aid, saying I need my money back, and they are then searching for a qualified audiologist. They're coming for a qualified service. Unfortunately, ma'am, as you said, like this can't be done in speech therapy because it is a very long process. My only question is, if some people, as sir you said, like some people are underqualified and they are giving stuttering therapy, so why can't any qualified speech therapist, even today I regularly on daily basis 3 to 4 people I interview, sir.
You see,
I ask
we can't give false promises. The difference between you qualified people.
audiology, this will also slowly eradicate.
So
It might take another 1 year, 2 years.
Yeah,
I can't give you the exact time frame, but this will definitely
yeah,
change.
that's what I was coming to. As you said, we have been discussing it in every conference. So the more we discuss, more awareness. That is why we are discussing in every conference. This was there in the medical field also. Even now there are RMPs doing practice. So this is there for a long time. So it will take long for us to do it, but we have to push more this thing. Okay, this is about main problem faced in many states, pay parity. So, Everywhere, yes, everywhere. Yesterday only somebody, Rashekar was telling about an institute where they were just giving a lump sum amount. A university grants UGC approved institute which doesn't follow scale pattern. So this is happening everywhere. So we are not worried about the institute. That is, the person has gone with his willingness to go there and work for whatever this thing. But in government institutions like state governments, so this pay parity is very rampant. Actually, Mr. Murli, he is very well known about the condition of this in the state of Andhra Pradesh. Unfortunately, his wife is not well, so he could not come for the panel discussion today. If he would have been there, he would have thrown more light on it. So I don't want to stress much upon it. If anybody wants to just add anything in the panel, you can leave it. Otherwise, we can proceed. So this thing.
Okay, this one, I mean, as you rightly said, this is a major concern. It's also a heartburn for somebody who says, I do the same work, but I get differently paid. Why is X being paid so much, whereas, okay, Y is being paid less? So this, when this question was told to me before by you that is going to come, I was just thinking about what could be the reasons for such a thing. What is the scenario in the Indian context, and what can be done to mitigate this? And I'm very sore about RCA coming and bulldozing their way into our program. But I'm thankful to them for one thing that gave me some time to think about and then jot down the points. So that way I'm thankful to RCA that they gave me some time. So I would like to divide this pay parity under different headings. Number one is that pay parity definitely will affect the sustainability of our profession as well as the development of a profession. Because when people see different people getting different thing, they also get disinterested. Now, if you look at it now, the disparity, you can divide it between government setups and private setups, number one. Urban versus rural, and third is across the states. If you take up the government sector, definitely because they have a pay commission coming up, 5th pay, 6th pay, 7th pay, automatically everybody right from the Jadwala to top fellow, he gets his due, right? So those of us who are fortunate to be in the government setups, automatically the pay scale goes up for them. And if you look at it, if you comparatively, the pay scale in the government sector is definitely much higher as compared to the NGO sector. Again, depending on what scale they are placed, right? They are getting the right scale, right? That's one thing. And better pay scales, job security, benefits are more as compared to working in Helen Keller's. Job security you're giving? Yes?
Now he's...
No, I'm just joking. Now, what I'm saying is government setup, they take for granted that nothing, I can do anything. Nobody can throw me out. But Khan Saab can throw them out next day itself. So what I'm saying is that fear is also going to be there in them. Okay. That next one is if you take up the NGOs, you take up the private clinics, hospitals, it's totally different. The entry level, the salary, if you take up, I'm talking about 20 years back, a BASLP would be getting about 15K, and MSc will be getting about 35 to 40K, but no longer. Now we have raised the bar, right? And even if it's in a NGO setup, a bachelor should get a minimum of 30, 35, and a master should get about 55 to 60. If it's going to be a rehab setup. That way, I think it's gone up. People have also understood it. Okay. And I would like to share what you said about a real life situation. When I went as an RCA inspector about 15 years back to a major institution in Bangalore, I wouldn't name the institution because, that's not ethical for me. So me and another friend of mine went. So we were looking at all the records, everything. So I said, who are your faculty? Their qualifications, seniority, number of years of experience. What is the salary package? We have a package. Then I asked, is it central government? No. State government? No. Panchayat? No. Your own? Yes. What is it? All fixed remuneration. There is no scale of pay. What's the scale of pay? You start with a thing and you have increment, annual increment. You got a efficiency bar. Then, you go up to that particular level. Next grade, again, it goes up. There is no scale of pay. And there is no annual increment also. No incentives. Then I asked them, why is it so? They said, faculty, nobody asked us because the institution had mostly women whose husbands were in a very high position, making a lot of money. For them, it was just additional money, pocket money kind of a thing, right? Then we said, as RC inspector, unless you specify a scale, pay scale for them, which could be either the central government or state government or quasi, whatever it is, we will not recommend your recognition because we could put that rider on them. Immediately, they had a scale of pay, and now that institution has a scale of pay. So the onus is on us also when we go as inspectors to make sure that we take care of this also. So that's one thing which from Andome Khana Raja. So the fellow is the best there. Whatever he does, he gets it. So that's the second thing about it. Again, if you take up the academic institutions versus private institutions, if you are in ISH, if you are in ABOJ NIHS, if you are in Manipal, you have a good scale because all established ones, you have a real good scale, pay scale is there. If you happen to be in a college or a university, now they enforce that you have to be an assistant professor, associate professor, professor. So naturally, your pay scale will also be there. But in a private institution, you will not get it again. Depends again on the institution, number of students that they have taken, the paying capacity of the students. Now you are giving.
No. Yeah.
No. But there are some institutions where the pay is totally different. I'm telling you because if you compare Manipal with some other, okay, you will find there's a big difference between what they pay also, right? But at the same time, you also have tough conditions for recruitment because we have raised the bar now that any academic institution, a faculty position, you must have a PhD. That's the minimum qualification. We have raised the bar. Raise the bar automatically. A professor starts with 2 lakhs now. So that once again, it's a question of being in academics or your clinical setup. Private colleges, even without PhD, you take them because you just want to show the number to the RCA. But naturally, because they don't have a PhD, you can't give them more. So they can't ask you for more also. But if you have a PhD, if you get a better pay, you have to also prove yourself and say that I'm going to get some grants, write some grants. I'm going to get a grant. I'm going to publish papers. I'm going to get patents. So all those things. So if you want better package, you should also be willing to do lot of more things also. So what are the factors which are responsible for the pay parity? Shrikant, what are the factors which are responsible for this pay parity?
Yeah, now I'll tell you what Khan was referring to is these days in government, they are not appointing on scales, they are appointing on contract basis or outsourcing,
Okay. Yes.
and there they are giving only lump sum as he said.
But that happens.
Yeah.
That happens only in one of the major institutions because I've seen the only contract positions.
Now what happens? No, you all people should know our consolidated pay was 12,000 rupees. Thanks to Sri Lakshmi and Sirisha madam who went and talked to Chandrababu Naidu and other top persons. Now we are getting 35,000 like that consolidated pay from 12,000, 35,000 it has increased. So we have to fight for it. I think there is a time is short, so we proceed to the next question.
So what are the factors which are responsible for the pay parity? Because we don't have a strong advocacy.
That's what we have to fight for it. We have to have a strong
lack of strong professional union. For example, ISHA cannot decide or dictate pay, but RCA can. Rehab Council of India, because if they can bring out and say, look here, if you have a faculty position, you must give them a minimum of so and so. Okay. Now this is not being done, so ISHA should take the onus of telling the RCA that you have to insist that for a lecturer or assistant professor, the starting should be a minimum of so and so much, which they're not doing because they are only interested in policing. Come like in the prison, your name, your photograph and all that. But I would like to share with you that I being in the advisory committee of the National Council for Allied Health Profession, though we are not in the council, but I'm in the advisory committee. This is one point that we have already mooted. So we have told that the National Commission for Allied Health Profession, which includes PTs, OTs and all that, is coming out with a minimum pay for a person under the cadre, faculty, non-faculty, junior, senior, supervisor, and that will have to be followed. Otherwise, legal action can be taken. So we have to have such associations and such push or such mandated. You have to have the limit by which I'm sure that our pay will also go up.
40 to 50 visits are permitted. So most of the special schools for the intellectual disabled are simply they are putting on the paper and not getting. That is what I have observed in so many places. Huh?
Yeah.
And because nobody is coming for 850 rupees, 1 hour people, no speech pathologist will come for.
That's what I see. In one meeting in Delhi, I told, they said, if you should get good faculty for institutions. If you pay peanuts, you'll get only monkeys, right? So if you want good faculty, you have to pay them also. Which means, you'll have to raise the. So now with a lot of educational institutions and even rehab centers, which are, ensuring that is going to be a good rehabilitation with, evidence-based practice and all that, you have to raise the pay. Only then you will get the best out of it.
So we are running short of time. I'll have another question for you. So this next slide, already we discussed in the inauguration this thing. So RCI has to do things. RCI is not doing things for us. So we were all discussing that we should somehow get out of the RCI and get into this health professionals council. So I won't stress much on this. So next. So now I want Sai to tell something about their organization, how they could manage and excel today, so that the fresh graduates can know and they can emulate their the story. Yeah, actually, he is. What is your position in HearZap? He is in HearZap. It's a, you might have heard of HearZap. It's a chain of this thing. They have grown exponentially in a very few years. They are into corporatization of our profession. So he is in the learning and this training department of the HearZap. So the Raja Pandian, who is the chief of that organization, was supposed to be in the panel. Unfortunately, he has to attend a meeting, so he has left. He is representing on his behalf. So please.
Thank you, sir. I would say, like, since this organization is there in the practice since 1977, so that's when we started. So we have seen this field evolving as well as the client taste evolving along with the product. See, there, I would say, like, today we have come into a generation of AI, right? The product is evolving, the client's needs and necessities are evolving, their tastes are different, but only question what is different is how good is a professional, or how is he developing himself, or what is he working on once after he crosses the checkpoint, that is his college. Once he audiologist or a professional passes out of his college, are they really equipped with the real time knowledge or real life knowledge, or are they really understanding how to deal with a client? Are they really understanding what is, because even today when we take the interviews and all, like, I reject bluntly many of the people not on basing of their technical knowledge, because they come with one motto: I have paid this much, so I should earn this much. So most of them doesn't even understand like what is really their inner hearing aid. They can't even say, like, they'll say, sir, there should be some microphone and receiver. They bluntly forget even the amplifier part. So if this is the case, how can we confidently say I'm a professional and I'm ready to guide a client? When a client comes and says, see, this is my problem, I'm suffering with this, and you doesn't know what to do and how to handle it. So this is the biggest gap, sir. And this has been ever since 1977. So I would say the success of this organization can be contributed, no, should be contributed only to one thing, that is a constant learning of all the audiologists. The entire team, everyone has a, they have a very clear defined role. They know what they are supposed to do, and they constantly equip themselves with continuous learning. I would say this one word should be more than sufficient, sir.
Yeah.
Continuous learning is the only thing which can help you all.
Yeah.
So that is the basic pillar of this
So
organization.
if you have to beat the competition, you have to upscale yourself. That's the answer. You have to learn. You have to be better than them. Then only you can say, no, you see, you do whatever you want, but I can still this thing. So that is one thing Sai has clearly told. So I was
Srikanth,
going through one,
just add up one to what he said.
yeah, yeah.
See, what I've observed from your people who are in your, it's a purely a corporate kind of a setup, corporate. But what I've seen is, besides the knowledge, the way that they deal with the patient, that's what is called the attitude and the professional demeanor, which, right from in 1976, I've been doing it. You talk to a patient, even if you think you can't help him, but the way you talk to him,
That's their part of the training program.
that the way that you sound to him, that optimism, that sincerity, that makes a lot of changes, a lot of difference to what you have. You're saying he's my client, I'll show him the high-end machine, hearing it, he'll buy it, tell him you got all these features. No, but the way you take it up,
Yeah.
that's a skill. Some it's inborn in them, but some they can be trained.
Yeah.
That's what you're doing, and that what makes the difference.
Yeah. So not only their centers have a same pattern, the way they approach their patients also have same pattern because of their training. This thing, it's uniformity there.
And one point I would like to add is, in fact, it has 2 points. As just to summarize on what you have said, I call it process, sir. So one should have a strict framework, like this is how my client should be treated. This is how he should be dealt, no matter whether he is a low-end hearing aid buyer or a premium buyer. And the second most important is he should feel like I am treated the same, no matter whether it is my first visit or second visit or my final visit. So he should have that confidence that when I go here, I feel more comfortable. These are my people. So if you can give that sort of a confidence to your client, he will remain loyal to you. This mere discounts and all, they are nothing when they compare the relation. So, and it is you who should give that value to the client. So when you don't add any value to yourself and when you don't add any value to your customer, so they'll forget about him. He'll no longer be your customer.
Yeah, I would like Nitish to conclude. Yeah.
I just wanted to make this, because it's becoming very formal and very serious. So just to add in a lighter vein to what he said about, the patient should feel that, it's the same first visit, second visit, last visit. It's like, you marry, the affection and the attitude that you have towards your wife on the first day of your marriage, and after 10 years, 20 years, 40 years, it should remain the same. I am married for 43 years. You ask my wife how I was on the first day and how I am today.
Everybody can't be Rajshekar. Anyway, Nitish.
So my thought is a bit different for the upcoming professionals. What I would how I would put it like is, there are good number of professionals out there who are very strong technically, but the point is they miss out on the core aspects of how to run the show. So at the institutional level, it is very important for every student to understand this, that it is not the academics which is solely important, and it is not the clinical hours that is solely important, but what you do in the clinical hours. And when I say what you do, is what you learn. And when I say what you learn, it means that as the patient enters your setup, your clinical setup, how you interact with the patient, how do you invite them into your place. Starting from there, how do you register them? What is the fee you take, whether you want to take the fee then or after completion of the services, depending on the type of organization you work or clinic or anywhere. You need to get exposed to each and every aspect of those. So when the patient enters, what is the experience, how you are taking the patient through the testing or through the rehabilitation aspects or through the therapeutics, how are you counseling them. And I think it is also important the faculties also should make a note that they train their students in such a way that they are ready very next day after they complete their bachelor's or master's, so that, let's say, if they want to open their clinic, what is needed? It is not that, okay, you have a setup and you have an audiometer and then you have a clinic. No, there is so many other things. There are registrations, there is a flow of patient. How do you complete a transaction? You also should learn to take money from the patient. So you should also be involved to some extent in the accounting, or the student should learn how does the accounting occurs.
Thank you.
Where is the institute making the profit?
Yeah.
Little idea, and that's where they tend to grow in a holistic manner. And when they come out with the experience, they will refine that, and they'll be good professionals soon. Instead of learning that, oh, these things also happen, and that will happen after 5-6 years.
Yeah.
That's too late.
Nitish, I think we are too much over time. Yeah, one question from
Sir, my observation, many of the colleges, staff are recruited at a certain amount of pay scale or maybe fixed amount. After they are getting some offer from outside for 10,000 more or 15,000, simply they leave. There is no ethics for professionals. Professionals should have the ethics. They do not have the ethics.
Yes, yes.
And moreover, somebody they are really looking for that. Arey, what is he paying? He is paying less. No, why should I work for that? Char birds gaye, chalo pack ballu chal jao. So how do you manage? There are lecturers. Many times I scolded. And some of the colleges, even they don't take the classes. Only notice board attend timetable will be there. They are not taking classes. Then what could be the product? The same product tomorrow will become the lecturers. Then how they will be burning? So this year after year, I am seeing so lot of decrease in the quality. I have seen with my observation. Because I worked in NIHH, I'm working with Helen Keller. See, I felt I used to fight with other my colleagues also, NIHH people and other people also. See, when we are thinking that improve the quality, how can be possible unless you people improve your thinking?
Yes.
So that is I request all the faculty, they should think what we have accepted for that particular pay, but we have to be justifiable. We have to help the students because the students are paid and coming for that. So their amount only being paid to you. So you should give the back to the students. That is the staff should have.
Yeah.
Regarding his comments, usually in the postgraduates and second years, we do have paper as called speech in practice and audiology in practice. Usually that is taken by the senior faculty. Usually like me, usually we take and we do teach the students how to behave, how to communicate, how to interact, as he said, how to take money, what all the things prerequisite to start a speech and hearing center.
Yeah, this course is a part of the course. I know.
It's a part of the course.
Part of the course. They take it only for the sake of passing exams. They take it serious. They don't take it seriously. Once they come out, when they face the real life situation,
Particular setup, they'll understand whatever we have taught during their college days.
Yeah.
How much is important, how much they need to carry out this.
Sorry, ma'am, we have taken too much time, more than what they have allotted for us. Sorry, I have to end this, but we are available for discussion. So we promise you through our state association. You see, neither APASLPA nor the ISHA is a statutory body. Any of our fight we have to do, or any of our problems, we have to take it to a statutory body through ISHA. So there is a hierarchy. So we promised through our association, through the present dynamic president, secretary, we will put up a proposal to ISHA. We have requested Rajshekhar sir to prepare some points for it, which we can put up to ISHA, and is that it goes to the proper this thing. Things will take time. Don't lose heart. We are doing well. We will do well. As Sai Koti said, don't worry about the others. Let us worry about ourselves. Thank you. Thank you.
With that, we have come to the end of the panel discussion, and now I would like to thank all the panelists and the moderator. Now I would like to request Dr. Indranil Chatterjee as a token of appreciation to come forward and present the memento to our panelists. The screen, the pictures were not clear, so we were requesting it. Thank you everyone for your valuable contribution. So students can now break for tea. Refreshments are served outside. And please restrict to the timings. It is only for 10 minutes. Please be back as we have another talk scheduled for the day. While the students go for the tea break, AGB meeting will be held here. So and all registered members are requested to attend the AGB meeting. Thank you.
సరిపోద్దురా తమ్ముడు సరిపోదు పర్లేదు ఉంచే
అన్ని పడేయకమ్మా ఏం పడేయకమ్మా బ్యాంక్వెట్లో ఒకసారి రావాలట అందరికీ వచ్చింది బ్యాంక్వెట్లో ఎగరాలి అందరూ
అలా తమ్ముడు వాళ్ళే కింద దిగమ్మా నా స్టూడెంట్ నేను దిగమ్మా నేను దిగేస్తే లేడీస్ వచ్చేస్తారు ఇలా
ఇక్కడ నందు జాయిన్ అయిపోవచ్చు ఎవరన్నా పక్కన రెండమ్మా తొందరగా ఫుడ్ అయిపోతుంది
కొట్టే కొట్టే తమ్ముడు బైక్ ఎక్కడ కనపడతలేమో చూడు కింద
అమ్మాయి కూడా వస్తారు ఎవరు రండమ్మా